So again, that was great. I think that was really powerful, actually. And I really love to have, or hear, I should say, both our patient story and also our staff story. So it really does help to ground us, particularly at the beginning of our board meeting. I just want to welcome everybody, and also to welcome Sarah, our chief nurse, who I believe is online, and hopefully we'll get to hear her later on in the agenda. Just for the purpose of the meeting, just want to read out the procedures for questions from the public at board meetings. So the board meetings are actually held in public rather than being public meetings. So obviously, this means that the public are very welcome to attend but cannot take part. Nevertheless, as the chair, I'm happy to conduct a short question session at the conclusion of each board meeting held in public to respond to questions which have been raised by the public or members of staff at the meeting. And members of the public, staff and governors are permitted to ask questions at meetings of the board of directors, and the chair will invite questions at the end of the meeting. Every question must relate to the items received or considered by the board of directors at the meeting, and questions should not refer to or require discussions of a confidential information nature, including personal information about any individual. The chair may interrupt to stop a question being asked where it's not relevant to the matters at the meeting or it discloses confidential information. There is no need for notice to be given to ask a question at the meeting. However, members of the public are actually encouraged to give notice of their questions to the Trust Secretary, and usually by 12 noon on the working day before the meeting, and that's to enable a full response to be prepared. No member of the public may ask more than one question at any meeting unless the chair allows otherwise. There are no limits to the questions for governors. The time allowed for questions by the public and governors is actually limited. The chair may curtail the time available for questions at his or her discretion. And where possible, a response to a question asked will be given at the meeting and recorded in the minutes. And where there's not, where this is not possible, I should say, a written response will be provided within 10 working days, with the response being reported to the next meeting for information. If a question has been asked previously, then the chair may refer to the response recorded in the minutes rather than repeating the response. So just wanted to start off with that. Are there any apologies for absence?
Chair, we have Leah Aria, Graham Rudin, and Steve Forsyth in the report.
And Monica. Yeah. It's a little late.
All right. Thank you. Thank you very, very much for that. Before I go into this, any declaration of interest in relation to anything that we're going to be discussing today on the agenda? Before I go further, we have our values, our trust values, which is compassion, committed and inclusive. And I just wanted to state that over the past couple of weeks, we do have two of our board members who have both had bereavements of siblings. One being Winston, whose sister passed away just a few weeks ago, and also we have Belle, whose brother passed away last week. So on behalf of the board, we do want to extend our condolences to you both during this particularly difficult time, and thank you actually for being present here today at the board meeting. Okay, so we continue with our agenda in minutes of the previous meeting. So while I'm getting on, sorry, I shut my computer down. So it's the minutes of the meeting on the 1st of February, and And if I just ask, are there any points of accuracy throughout the whole of the minutes? If one going down, anybody wants to raise any points of accuracy, anomalies, or anything missing from the minutes? No? So we can accept them as a true reflection of the meeting which took place on the 1st of February. And then in relation to, we move on with the agenda, in relation to the action log, I believe on there, most of the actions there, they're actually picked up on today's agenda. So we're just checking that again. Yeah. So most of the action points from the last meeting are picked up on today's meeting. So if we move to the chair's report, so the chair's report is there for anybody to raise any questions of my report or queries or anything that you want to ask at this point.
If you can, there's a comment about the police that you met, etc. There used to be, I think, there used to be a reference on the council governors who have been appointed to the police.
Yes.
So I don't know, I can't run a reference back. I think they chose the steps, right?
Yes, 100% right, Dave. So I actually reached out to Tom McNeil and asked if I could have a meeting with him to look at seeing if we can get a representative from the police. Apparently, Dave is probably the best person to answer this question, but that person who was a governor on the board was really productive and very helpful.
I think he was working at the Westminster Department of Forest, so he sort of a bit of a contact from that point of the land use business as well.
Yeah.
That's the reason for it.
Right, right. And I think it's really, really important. So I did meet with Tom at the, I pointed to the ICS and then mentioned it, said we would firm that up. So my intention to do that. Brilliant. So if nobody else has got any questions in relation to my report, if we continue moving on with the agenda, which is the Chief Executive and Director of Operations report. I'll hand over to Julian.
I'll start and then I'll pass over to Vanessa. So I'll take the report as read, but just a few things that I wanted to highlight under our 4 priorities, strategic priorities. So from a people point of view, I wanted to say a really big thank you to all our colleagues who pulled out all the stops to create as safe as possible a scenario that enabled our doctors in training to, we wanted to take industrial action during the recent industrial action. And I want to say a big thank you to those that are working on our planning for the next round of industrial action. It'll be more of a challenge for us to provide the right level of cover, but we have a number of contingency plans in place and they're being worked on, particularly led by Giles. So, I know that a lot of our consultants and our nursing colleagues stepped in to really support and I know that they're keen to do so again. I also wanted to just highlight the fact that the 360 tool is now in a position to be launched. I think in the report it talks about almost being there, and we're intending to, those of us, the senior leaders who've had our leadership development, we will all undertake that 360 degree. And we will also be applying this to our Enough is Enough process, whereby people have been highlighted by others speaking out around their behaviours. There will be, this will be a tool to support them to understand better the impact of them on other people. So I just wanted to say that's been a while coming, but it's been very well consulted on them. And I think the tool now is probably as quick as it's going to be for us to launch and use. I wanted to highlight to the board the additional work that's been going on around wellbeing, particularly through the steering group around cost of living impacts. And you'll see in the report the more recent work that's going on in partnership with a local charity around the provision of clothing. And I know we found that we still find it a real conundrum, don't we, to be in these positions in an organisation, having these conversations about how we support our colleagues, our staff, in these circumstances, but it's very much our reality, and our student colleagues do great work in supporting the initiatives in place. We've obviously got a number of people orientated reports today. We've got our resident data and our staff survey and our gender pay gap reports. I've also included the work that was done during LGBTQ History Month. And as a board, as you're all aware, the reason we're wearing our lanyards today is that we all signed the pledge around anti-discrimination and prejudice, and committed to do our active bystander training for those of us that haven't, but I think the majority of the board have now completed that. From a sustainability point of view, it's clear that we're ending the financial year in the position that we expected to. Obviously more on that later. However, we recognise that the coming year is going to be particularly difficult, and we're having lots of discussions as a system across Birmingham and Solihull about a number of things, how we work better together, but including around finances. From an integrated care system point of view, just wanted to say a massive thank you to our colleagues internally and externally, and particularly our voluntary sector colleagues, our experts by experience, who worked with us to develop the proposals around becoming the lead provider for the mental health provider collaborative. And after a short period of functioning in shadow, we went live on the 1st of April. It was no mean feat by all concerned, to get us to that position. So we now have a really great opportunity to think about how we can realise the benefits for better outcomes along the lines that Keith and others have been telling us over long periods through their experiences. I wanted to congratulate Carl Beats, who has been appointed jointly by ourselves and Birmingham Community Trust as the lead director for digital, but also for informatics. You know, I think this demonstrates again the work about collaboration, that we're no longer in a position where we're looking to keep our own people to ourselves for our benefit, but recognising the benefits of wider systems and our population. So first of, I think, probably a number of joint appointments that we may well make, but congratulations to Carl. You'll note in my report and in the quality assurance chairs QPES assurance report from Linda, that we've had confirmation around where we sit in the NHS oversight framework, and confirmation that we remain at segmentation 3, both as an organisation and as a system. From a quality point of view, we've obviously got Lisa Pym joining us later to take us through the patient safety report. I've mentioned the CQC inspection, and we now have confirmation that our report will be published on the 14th, so next Friday, with publication of that report, and we're obviously already in preparation around some of the action planning, and also some of the media planning with the CQC around that. I also, under quality, wanted to raise the fact that many of us may have had the opportunity to watch that very distressing Dispatches programme about a service called BrightNet, run by an independent provider. Just wanted to alert the board and the public to the fact that there are 2 Birmingham and Solihull resident citizens who are within that service, and we've been working closely with our colleagues in Bolton and also our ICS colleagues to determine onward plans for those individuals once the deregistration by the CQC comes into force for that service. And there is one individual who we've got a very clear plan for. There's a second that we've got a clear plan for, but it may not be enacted within the timeline, so we're looking at what an interim arrangement might be. But we're working with the national, the regional, and the local RCS around that. On other issues, I just wanted to, I've included a number of reports that have been issued since the last met, just to confirm that I've included the Michelle Cox case, because I think it's really pertinent to our value of inclusion, to the work that we're trying to do around anti-racism and anti-discrimination. And I think it highlights some learning for all of the NHS, including us, and so we've begun to have some conversations about what is the learning from this, from our own perspective. Just also to confirm that the HEWIT review was published yesterday, so we will obviously take some time to think and consider what the implications of that might be for us. Although I think it's quite well documented already that it's pretty silent on roles and responsibilities, and particularly responsibilities to provide organisations versus the ICS. So a lot of work I think still to do around that. Three other things I just wanted to mention. The NHSE board will be meeting in Birmingham, having their public meeting in Birmingham in July, and we'll be looking to visit services, and we're very keen for them to visit some of our services while they are here. I wanted to publicly congratulate Patrick on his appointment as Deputy Chief Executive. And I wanted to congratulate our bipolar service colleagues on their shortlisting for the HSA Digital Awards for their Mood on Track app. So we look forward to hearing how they've done in June, but of course they're winners in our eyes already. And I'll finish there and open to any questions.
Are there any questions for Rashid? No? Okay.
Thank you, Chair. So, just a bit of a whistle-stop sort of summary of our community services and under our community by CCR services, specifically focusing on community transformation, which is really going really well. We've got an engagement event with GPs, which is like our interface with our GP colleagues, ensuring we've got really clear pathways of care and support. We've also got a piece of work around health inequalities, and we've posted a question around how we work with community teams. But I've asked if we could maybe put some more detail into the report next month. I'll do that, just around what we're doing around health inequalities and the actual groups of communities that we're working with, because it's a real good story that we can share. Services sort of in general are really focusing around well-being, around demand and capacity. That continues to be a challenge across all of our pathways. Again, across all services, some good news stories around new services that are going live, particularly our community rehabilitation service. This is a service that sits in between our assertive outreach team and the community mental health team, and it's looking at supporting people with long-term rehabilitation needs and helping to support and with their long-term sort of goals around housing, ongoing support with community leads and developments as well. I've made a note here around ADHD. Absolutely, acknowledging that we do have long waits in the service, and we're doing a piece of work across our system, which is really encouraging, as I felt sort of like sort of in past experiences, really working on our own, but working with our other providers, including our GPs and local authorities, around what is our model now across BSOF, really breaking down those barriers now and actually, how can we move forward. We're planning an event, an engagement event with our clinical teams next month. Actually, let's all get in a room, let's just work this through, how can we work better. Some particular work, particularly looking at some of the long waits, not just with ourselves, but with our other providers in the system as well, how we can help and support service users there. And secure and offender health, a big focus around recruitment, which is working well. We've recruited only three, but it's really good, third year students that are due to start in September or the autumn, which is really good. The team are really pleased around their recruitment there and supporting them in the meantime before they start with us. I made a note around the first leadership team, that's our community forensic team. There's some changes around service manager, OT, and advanced nurse practitioner, some changes around leadership there, which is really good. And we've recruited to the posts, so they're due to start quite soon. Also just to acknowledge that they're working with other services as well, so steps to recovery and with community. So I think, the good news story around all of our services now is that dual linking between where historically there's been sort of, divides between our operational services. That's really good news. Acute and urgent care, again, a real focus around staff experience there and around demand and capacity. We're getting most of our pressures in that area of our operational services. Good that we've recruited some staff, and good that we've got SAS doctors coming to our home treatment team, so we had some vacancies there. So that's really good. Acknowledgement that we've put extra resource into our PDU, so our psychiatric decisions unit, which also houses our place of safety. And the team there are working with our acute colleagues, as well as our local authority colleagues, to ensure the flow going through our A&E departments and help and support people then into other pathways. Notes just to say around in dementia and frailty. I think again, it's just to note the high acuity on the wards there, and the staffing challenges that we've been having. Again, good news stories around recruitment, but also around the additional staff that we have on wards to help with acuity. So that has actually been sort of worked through on a week by week basis to ensure that the shifts are covered. I think just finally, again, just to make a note around our memory assessment service, again, sort of we've got rates now, we're looking at some of the detail around 6 months for initial assessment. We're looking at how we can shorten that pathway, so the teams are working together to look at that. But also, as opposed to having an initial assessment and then, you know, sending people for a scan, can we do the scans first, so we've got all that information in advance, which is good news for my mum who's been through the service. So that's good to see there's some developments there. I think I'll stop there. I mean, I could talk probably forever.
Thank you, Vanessa. Are there any questions?
One comment and one question. I'm not sure if you'll be able to answer the question. The children isn't used like that. Just to say, in my attendance at other RCB meetings, I think it's just important for the full board to know that they spoke very highly of the leadership from yourself and the trust in relation to the mental health strategy work, about how it's really kind of developing place and developing joint working, the concept of system-based working is really coming through. So well done. Thank you. That's a great tribute to you and to the work that you're doing and to the organisation in terms of the principles that we try to put into what we're doing. So just wanted to, it's been spoken, not been dispatched. I think it's important to know. The question though is more about, we've got some additional staff and we talk about the kind of newly qualified starting at Armley, and that's fantastic, you know, getting people to come back or come from other places. But I think there are we clear about what safeguards we're putting in place? Because although they're newly qualified and they've done their experience and placements, etc., we clearly have some areas where we're not always able to put 2 RMNs on, for instance. What are we doing to make sure that we're not leaving those people kind of in a place where don't quite develop the experience to run a ward on their own, if you're with me? I just think how are we building that through? I mean, it may be something that you can't answer today, but how are we making sure that reinforcement for them is there? Because we don't want to start with feel so stressed and then leave again. So it's just making sure that we're working that through. So can you talk about that for us?
Yeah, I mean, I think there's a suite of things that we do to help support especially new recruiting staff, especially in an area where it is, you know, we have quite complex service users. So sort of, you know, the support, the wraparound support is obviously people would be on a shift on their own straight away. It's kind of like a buddying system, so we would expect staff to work alongside more qualified staff. There's a robust induction, you know, getting used to the service, getting used to the service users, so, you know, and that's a corporate sort of induction we have, but also like an induction which is getting used to the local area. There's the building the relationships with each other, there's the building relationships with staff as well as that. There's a suite of training as well, particularly for that unit and other units which you spoke to them, so and making sure that, you know, staff are going through that training as well. There's RMS, you know, regular management supervision, there is clinical supervision with staff as well, so we'd expect the staff to be, you know, part of that from day one. You know, and there is acknowledgement, you know, and the service manager Emma does acknowledge this, you know, that looking after our staff and their well-being when you start in that environment. There is a note that she was saying that, you know, that the students that have started are students that have worked there before. So that's really good because they want to come back and work there. So, you know, the 3 nurses that started aren't new to the area, but absolutely they would still be, you know, party to that induction and to that support.
Yeah, no, I think that's really good. I did an induction yesterday, I met 2 or 3 people who have done their placement here in a variety of different places across the trust. And they have all chosen to come back and
Yeah, it's
they're just
great.
full of excitement and, you know, really enthusiastic about what they were doing. And I suppose what struck me straight away was, please don't put the ball down the road.
Yeah, absolutely.
And let's support them properly, because I think
Yeah.
they were bringing such enthusiasm.
Yeah.
It's just a really positive thing to say.
Yeah.
And, you know, just to make sure that we don't, you know, we wouldn't abandon them, that's not quite the right phrase, but, you know, place them in a place where,
Yeah.
where it doesn't end up in a good place for them.
Yes.
Yeah, if I could just add about our practice educator roles. So remember that we introduced those in recent years, and they're also really designed to really focus in on giving people the practice education and support, you know, in situ and by working alongside. And we have got some really good stories from our practice educators where they have identified new requirements of staff have gone in, particularly, for example, one person went in over Christmas and worked alongside on the shift with somebody who was relatively newly qualified to enhance their practice education and to give them that kind of support as well.
No, that's right, that's good to hear.
Patrick?
Yeah, I was just going to add that in that process of preceptorship is really important for those qualified staff, and they will then become our advocates in terms of attracting people into the organisation as well. I think that is really key. But also, as I say, that we also want to make sure that when we do have instances like that, they put onto the system, to our SCI system. And we have started to see staff doing that where they have concerns. So to make sure that we have ways of mitigation, also reporting where we have issues of concern that we can address.
Okay. Yeah, that's really helpful.
Thank you.
Yeah, thank you. I just want to pick up something from the December action note from last board meeting, where it says that there should have been an update on the forward plan for the clinical strategy to be shared at this meeting. I was hoping we could pick it up in the report itself. So do we have a forward plan for the clinical strategy?
Sorry, I've made a note here. So we've got all the review of the strategy that's coming to our committees in May, that's correct, isn't it? And there will be, all of it then will come to board in June. So the clinical strategy won't be on its own, it will be with the rest of the 4 domains coming through. That's correct, isn't it, Patrick? Yes, we agreed as an executive a month or so ago. So yeah, my error there, I should have picked it up in my report. And actually read what I've written down. That's what you expect sound glasses as well.
Thank you.
Just a couple of questions, Vanessa. In terms of ICCR, there is nationally there is a demand, an increased demand, particularly for the service and community services as well. And I noticed in the report 2 areas in particular in terms of solar, which is a bit concerning. Obviously, they've got challenges, as we all have challenges across the board in terms of recruitment. But in terms of young people services, what impact of the challenges of recruitment is that having actually on the service, and actually getting more young people, you know, appropriately assessed and supported?
Yeah.
That one first.
Yeah, I mean, there are vacancy gaps in there. We're working with colleagues from Women's and Children's around sort of what that integrated pathway looks like. I suppose the impact is on waiting times. So that's that has been highlighted. Yeah. So which is why, you know, people who are waiting, we see people, we're reviewing caseloads, reviewing waits, and making sure that people are seen quicker if they need to be seen quicker. We've had some gaps also in the home treatment team, and again pulling on resources and support from our TV colleagues as well. We've been using bank staff, so we've had some really helpful bank staff who can offer a couple of days a week, so that sort of helped out, as well as bringing in some agency as well who obviously we induct into the service, making sure they're absolutely clear and okay with how it works. So there's again, recruitment going on all the
Yeah.
time in the background. Solar also works with Bernardo's and Autism West Midlands, so we're a really tight team in Solihull. And again, working with Bernardo's, can service users come into a different area of the pathway? They deliver sort of the lower sort of or early intervention sort of type work, how we work together around that pathway with them as well. So the team are always thinking about that, always very, very mindful of the vacancies there and the impact that's going to have.
Yeah, just so I think this is really where the whole opportunity around being provider collaborative comes in. Because, you know, if we look at from a population health point of view, 16% increase in demand for mental health services post. And if you look at the young children and people piece, that's even greater. So there is something about we're not going to be able to keep doing things like we're doing in order to continue to meet that demand. So a real opportunity through the provider collaborative to think about what a model of care looks like for children and young people. So we know, for example, in the partnership that the model that we've got in Solar and the model that we've got in what's called the FTP side of things are very different. And now maybe we're getting similar outcomes, and that's something we need to look at. But we're certainly going about it in slightly different ways. And so there's an opportunity for us as leading that collaborative to think about how we continue to keep services sustainable as well as meeting demand as it comes through.
So on the back of that, then, in your report, it also talks about the mission frailty and make reference to the demand and capacity pressures that continue, and also the complexity and acuity and increase in referrals. What is the plan around addressing that? Because that's a statement, but there isn't anything that actually gives us any assurance of, and this is our approach to that, whether that's a collaborative approach or whether that's a resource issue, or, you know, how are we addressing that?
Yeah, I mean, that's a good point raised, and that's mindful of that in there. I mean, I can detail that sort of next time just around it, because again, it's a bit of a sort of statement, isn't it? It's like, oh, so there you go. Yeah. So yeah, the teams are absolutely working together. So dimension priorities it sort of sits as a direct, as a division on its own. So what we're doing is looking around all of the community mental health teams. Is there a resource they can share? Where is the biggest demand coming through? Can we shift staff around to help and support where their demand is coming in? Again, we've brought in some bank staff, and we found that community staff also from the memory assessment service can help out, and in the CERT team, which is our community enablement team as well. Again, looking at the caseloads, can we discharge people quicker back to GP practice, which would then be picked up by the community transformation, because we have staff in the GP surgeries. So maybe I need to articulate that a bit in more detail, and we can bring it to performance delivery and to FPP committee as well, to give some assurance to board members actually there is a plan there, but obviously hasn't been described as well as it should be in the board report.
Would that plan not necessarily be short-term, but also be a long-term plan?
Yeah.
Because obviously, if demand is increasing and referrals are increasing, that's not just a now issue, is it?
Absolutely. There's a short-term plan, obviously, because of risk, because of caseloads. But the community transformation is more of a long-term plan. So we know we've had funding for the last 2 years. We've got another 2 years as well as part of that. And the roles that we have that sit in the GP surgeries, as we're now beginning to recruit, are the roles that will prevent service users coming into secondary care, because they can be supported in primary care, and then have that link and that pathway into voluntary sector organisations as well. So I think probably trying to explain that in some sort of, a diagram would actually show that probably a little bit better than sort of lots and lots of words. But you're absolutely right.
And some of the data as well. So that
The data,
the existing community transformation teams, you know, even just one of those teams has had over 1,000 referrals. And the concerns that our clinicians have about the fact that they wouldn't be held there, that they would still come to secondary care, and 50 of those came into secondary care. So it's, you know, there's some, that transformation is having some really good impacts. And it fits with what Keith was telling us about that earlier intervention, and supporting people not to come into secondary care, it's having some of those outcomes that you'll probably share some of that.
Yeah, definitely.
Thank you.
Just on that, I think there's this thing, we've already said a couple of times about transformative piece, and I think with the circuit, you've got to do both the day-to-day to keep it working, which is really important, while we're getting that, but we're really got a lot, not just in the mental health part, around places like this as well,
Yeah.
and we're working on top of anything, because it's clearly, you can't sustain services as they currently are, and they're not as effective as they need to be because of that. We know the shortages of staff, so we've got to really look at it differently, I think. But do that around the needs of the patient and what we can provide. And it's just how you do that transformatively across the system. That's what it should be
Yeah.
working through.
I
It's
think,
difficult
yeah,
to improve
absolutely so.
the current urgent management is the really development.
Yeah.
That's the secret. So you've got the opportunity to do something about it.
Yeah, and I think the beauty of the community transformation is it's not like looking at, you know, Birmingham Solar as a whole, it's actually chunked down, you know, so therefore we're engaging with the primary care networks, we're engaging with other organisations, so, you know, you've got that approach from a place, from a locality. So yeah, I think it's, yeah, we can describe that in more detail. What's the like, and I know we've been asked before, I think by Val, you know, so where are we getting to, what is the end result of all of that, what does, you know, does it look like? I mean, we'll always be involved in developing and something like that, but I think it would be good to sort of give a bit of a snapshot of how that's going to look.
And I think in response to part of Dave's challenge, we are in a position where we can do some appreciative inquiry internally because of the fact that those elements are already in place. And I think that, you know, that's the approach we know that we've learned from that engagement and the support of others to develop a plan and what it needs to look like is why it's working.
Yeah, exactly. And it's just how we do building that again in the other areas. 'Cause we've got the same in a whole series of different areas.
So, yeah, it's trying to describe it on a page with a diagram. There's my challenge, Vanessa. I'll keep you awake tonight.
And all through stories, because people will have stories.
Absolutely, yeah. We've got some good stories actually. We'll see stories.
Great, thanks, Vanessa. Are there any other questions for Vanessa or Sheen? No? Okay. So moving on with the agenda, we have our board overview trust values, and this is where we ask from the board members just to give their experience and overview of how they've seen our trust values demonstrated, either in visits or interactions that they have with other colleagues or services within the trust. I'm going to ask Linda just to give her overview of those values.
Thank you, Chair. I suppose it's thinking about, as Phil said, that everyday interactions and sort of standing back from that and observing how our colleagues are relating to each other and relating to staff, the way we talk about patients, the way we treat patients, the way we treat our services and colleagues. And certainly just observing forward today, I would say I've seen compassion and commitment in action, really. So thinking about what Keith taught us and thinking about how we're committed to addressing that sort of overall approach. We've just had that conversation now around that pathway of how we think about early intervention and how we continue to sort of drive that, and certainly the sort of inclusion agenda there for me in terms of thinking about the population that Keith represents and what we know about the concerns we have around how Black patients end up in more restricted arenas and more restricted sort of legal frameworks. So that was a really strong one. In terms of compassion, what I've seen board is even before Phil's introduction around our colleagues, you know, there's been the active inquiry of each other, that sort of checking out that people are okay. We've had other colleagues who've had difficulties with their health recently, and seeing that in action of how people are checking out that they're all right. And actually I saw at one of the committees
last week that it actually came from several colleagues that there'd been a number of staff who hadn't been well. And I think there's a risk, isn't there, with our team's way of working. You sort of feel, well, I'm at home, but I can do this Teams meeting because I can just switch the computer on, and I'm not very well, but I'll do it anyway. And actually sort of saw that what happened was that several colleagues actually offline and online had said to that other colleague, no, you're not well enough. Don't come to the meeting from your home. And just sort of saw that compassion in action, really. The other thing that came through one of the committees was our changing approach to how we deal with patients and families when things go wrong. So, for example, in one of the assurance reports, there was an incident on Sage Ward, and as a response to that incident, we took a very proactive, compassionate approach to immediately apologising to the patient and their care and service user, because I think there was potential issues around that the patient didn't have full capacity to receive the complaint, but that we were proactive in going out and making a sort of advanced apology before we had necessarily fully, resolved what the issues were, but we immediately resolved those issues once we knew the detail of them. The other sort of example of seeing our values was in the recent interviews that we conducted for the chair of the trust, and just seeing how inclusive we were in our process, involving stakeholder groups from outside the organisation, from within the organisation, but also how we'd taken note of previous senior appointment interviews where we had asked experts like CMS to take part, but actually they felt that they'd taken part, but their views haven't been fully involved or included in decision making, and that this process we seem to take that on board and really look to how we could involve our stakeholders in truly helping us to make that decision. So I thought that was a really good example of how we're implying inclusion in practice. I suppose the other aspect of the commitment today is just seeing again through all the different papers and the conversations that we're having with the different committees around how we're looking to support our colleagues in terms of their well-being, addressing concerns that we know are there around increasing acuity, for example, staff assaults on staff, and just thinking about how we improve things, but also seeing that we're going out as a board, as an organisation, to encourage people to be brave and to speak up, and that we will listen and to sort of take note of concerns that they have in the services. So it's quite a wide observation today, I suppose.
Thank you, Linda. I think it's really important for us to stick in how our values are not just words that are written on a piece of paper and look good for the trusts to have posted around our services, but we can actually talk about them and actually say how we've actually seen how we've been compassionate and committed and inclusive, and actually demonstrated from a board perspective, and also what we would like to see as well, that is that sort of board visibility as well, so that we're able to show our commitment by actually going out and visiting and listening to both our staff, our colleagues, and also to those who use our services and patients. So thank you very much for that board overview.
Just wanted to add something to that really, in terms of, I think that we've got a few papers on the agenda today that will give us an opportunity to understand that we've still got quite a long way to go for everyone to experience our values. And I think there's something about, it's important that we're reflecting about where we're seeing this showing up, but that we're also paying attention to the information, the data that's telling us where they aren't showing up and what that might mean for us. I think we've got an opportunity today to do a bit of that kind of discussion as well.
Definitely.
Yeah, I agree with that, and that was actually one of my notes, was we've clearly got that commitment and we need to show that today in our discussions around the staff survey and the rest reports.
Yeah.
We've got that there.
Thank you both. Well, actually, back to you, Linda. We have two assurance reports. February from the acute-based quality patient experience and safety committee. So it's the February report, assurance report comes in March. So,
Yeah, I'm going to just draw out of those a couple of points from the February reports. I'm assuming people have read the reports, because a lot of it continues through into both committees, so I'll probably spend more time talking through the second committee, and Winston was chairing the first committee in my absence. I've already spoken, this is February report, about the stage action plan, and that was in relation to the way we approached the incident, but also how we then were proactive in offering an apology and inclusive in that. I will only mention, I know Sarah's on she isn't she?
Yes.
Yeah, and there are some ongoing concerns which we are going to discuss at the next committee around some recent concerns around our use of the locked doors issues in acute inpatient care, but unless Sarah wants to add anything else, my understanding is that Sarah's going to bring us a detailed summary to this coming committee. So unless Sarah wants to add anything, I'll just go back to this addition. I'll move on.
That's fine, there's no short.
Yeah.
Thank you. Just
And again, from that February committee, we also assured that we will have an audit plan for clinical audit plans. Although we were sure that there were plans, we weren't sure that they were fully coordinated. So we understand that an audit plan has been finalised for the forthcoming year, and that will there'll be some sort of topics that will be generated for audit that will link and be aligned to our trust strategy. So I think that's something that we're looking to have at the next meeting. Moving on to the March meeting. In terms of the CQC report, obviously we've been acting on the previous recommendations, but we will have sight of our plans for how we're going to respond to the most recent CQC assessment. So that will come to this committee this month. I just wanted to comment that we're pleased to see that the NHOS data collection has now started, and we're expecting an update on that in July. And we're also pleased to continue to get safer staffing progress reports, because of the impact this has on policy. Thinking about serious incidents and learning, we actually had a really, really good detailed discussion about the data that we're being presented with. We were still only partially assured in that certain clinical areas have been identified as having where there are concerns that there will be more focused support in those areas. And we asked for further assurance from clinical governance on progress of those specific action plans. I think quite a lot of these issues will be picked up in Lisa's report in terms of the patient safety report. That looks like an excellent way of reporting these issues in one place and seeing how things track through. But we, for example, understand that the new safety summits will be really helpful in establishing where there are sort of more drilled down safety and quality concerns with either individual wards or divisions. That there will be sort of a really good sort of overview and analysis and action planning going on around that in the safety summits. And I've also made a note that we understand that the ward accreditation programme is being concurrently considered. Thinking about our QI framework, we're expecting the paper to come to committee this month again on the QI framework that is to be that we're proposing, and the internal investment in resources that will be required to achieve those outcomes. Moving on to the monthly policy report. We were assured as a committee to see a deep dive in all the incidents that are currently open on the system, some of them dating back to 2011, when CLIPS was first moved over into the organisation. But we're assured that there's a methodology now for safe closure of these historic incidents, and that this methodology is going to be taken forward by the patient safety team in collaboration with clinical governance and divisional leads. We were sure that we continue as an organisation to still have high levels of reporting of incidents, and the trust remains below the national average for incidents resulting in harm to patients. We also had a very detailed discussion about restrictive practices in the organisation, including, as Keith described very well, different ways that can take place. And we are expecting a deep dive paper to come to committee in May from the restrictive practice steering group. We also agreed to move to a quarterly quality report with monthly exceptions. But the thinking behind this is to enable us to have a more thematic and trend analysis of what we're seeing, and that will also include us being able to look in more detail at the health inequality information as well. I think that's going to be really good way going forward. Coming on to complaints, we were partially assured that of the complaints handling process, and that there is some progress being made on reducing waiting times. And we were actually pleased to note, and that's actually something I was going to mention in my values, again, the changes in, and it's in the spirit of the new PISA, the patient safety framework, of that in terms of when we conclude investigations, rather than previously we would write to families, patients, saying that the complaint had been upheld or not upheld, which obviously how that is received can be quite challenging at times, and the new process will contain an apology rather than that is not upheld. I think that was all I had to say. Any questions?
Are there any questions?
Yeah, just a couple for me, if that's okay. This is the report that's got the activity around the mental health legislation activity. And I'm not on computers and I'm not linked into it, so my knowledge is probably not where it should be. I'll be brutally honest with you on that one. But what I was quite interested by was the number of reviews that occur on cases by colleagues, but actually then the actual percentage that are discharged as a result of that review. And I just was wondering, it seemed very low for the amount of work that's going on, and I was just trying to understand that. So I wonder if it's possible for someone to just give us a little bit of an explanation about why it would be like that. I suspect it's something to do with legislation, but who knows? And the other question is on a slightly separate. We want to give you both the questions and then people can help. When, in terms of the complaints progress, clearly there's an issue in terms of the challenges of getting investigating leads in terms of complaints. It's interesting because there's a similar issue arising for freedom to speak up. And so I was wondering, what do we think the strategy is going to be for trying to improve that? People, why is that happening? Is it because people are reluctant to take investigations, or they're feeling too under pressure, or what is it, and what can we do to make sure that we can improve that situation? It might be resources, but they're different completely questions. Yeah.
John, was going to take the first one.
Yeah, so just when people are detained in the Mental Health Act, it's reviewed regularly by the consultant who's looking after their care, it's not the clinician. And their job is to discharge them from the section as soon as they think that's appropriate. So the only patients that should be going to a mental health review tribunal will be those where the consultant thinks that they still should be detained. And so it's likely, I suppose, we've already discharged people who need to be discharged. And so to go to the review tribunal and then to get discharged, that would be unusual, simply because we've already got rid of everything. We've discharged everyone who ought to be discharged, and then it's just those trickier cases where we may go to a tribunal just to get another independent.
So although there's all that, what we're doing is we're auditing someone's reviewing that situation and therefore having people remaining in that situation.
So-
It's a reassuring in the sense that we know that the consultants, etc., are making a lot of improvements,
Exactly.
and hopefully ones.
So it's always going to be low, isn't it? I think the bit of the report which we're quite proud of, I suppose, is that our lay managers discharge off section the same number really as people in mental health review tribunal. So it means that we've got a really effective lay management process as well. The number is low, but it does happen sometimes. I suppose it's just being brave enough, maybe, that's not necessarily the right word, but being diligent enough to make sure that people are discharged when they should be discharged.
Okay, lovely. Thank you, that's really helpful.
Just picking up on the question around investigations. So certainly it is a challenge given that our managers are stretched in terms of capacity. This is something that we have considered as executives, and we have put some additional investment into putting in additional capacity, pulling in some external capacity to support us with investigations, because it's important that we do investigations in a timely way. So it is something that we will be testing out, see how effective that will be, but we've already made that commitment to invest in that.
Okay.
Thank you. Just a couple of questions from me to the committee, rather than directing it particularly to Linda. On the report, it makes reference, you'll have heard me mention this previously, but makes reference to the CTO, the Consent Treatment Order Evaluation Review. And I know that this was first aired or discussed probably around 15, 16 months ago. So I just wanted to get some kind of update on when that evaluation, and I know that we as a trust will be, we will be the first to have undertaken such a comprehensive review to have a look at why particularly black males are detained more than any other ethnic group. So I just wanted to get an idea of when's that likely to conclude, John?
So hopefully it should be going to QPES this soon. So it has been written. So I think it's, so it should go to QPES first, but it has been completed as it's just trying to report those resources and make sure it goes through.
It's this month.
Yeah.
Remembering correctly. I think
In the near future.
it's either the first one this month, because we've got two, or the beginning then, I think.
Yeah. So it
I'll
has.
make sure it's there actually.
Yeah. So it's been done in 2 stages. So the first stage was looking at the quality of the detention of the CTO, which has been completed. The next bit was then trying to understand a little bit more information about those people who were being detained by talking to the individuals who are doing the detaining. And so both bits have now been completed. We're content that the people who are detained under the CTO, it's appropriate that the CTO has been used in those cases, which is great. But there's still the disparity there. So what we're trying to do is then investigate a little bit more about what was the thinking of the individuals who were doing the detention and why was that the disparity. So we'll, that's from Zoom.
That's great news. I'm really
I'll
pleased to
check
hear.
on that.
Check that's actually coming. The second one, I actually pose this to all committees, it's not necessarily pertinent to QPES, but just would ask the committee just if they could reflect in their report how on their agenda they have reflected on health inequalities through the lens of quality. So just some kind of statement, so it just kind of keeps it at the forefront, rather than it's just a passing statement that, oh yes, that's one of our priorities, to actually ensure that we are making a concerted effort to address health inequality.
I just wanted to up on that point, so we've had some discussion both with the executive and with our cultural diversity and inclusion lead around the work that we've put in play for executive leads and committee chairs to have some discussion about 2 or 3 particular health inequalities that each of the committees is going to concentrate on. And Jazz, as our EDI lead, is going to be doing that work. We've had quite a lot of change, as you know, in the board and then with the committee chair and executive sponsor. So that work's being done so that it will help to really focus in on, because we recognise our health inequalities agendas in enormous. So in order for us to be able to really focus in on 2 or 3 things with each of the committees. That's the worst that's been done. I think it's probably clearer in our committee that presently than perhaps it is in.
Yes.
Yeah, it's expanding that. So I think the commitment that we've made in the committee was to report properly on specific metrics around this, which we have been doing for a while. I think it's reflecting sometimes on, are we measuring the right things? What else as a committee do we want to see? And also bringing in that assurance that you get when, as non-executive, you have to what are you hearing from colleagues as well. I think what's important is the experience of colleagues in the organisation and some of the assurance that we bring into the committee around what's the things that we're putting in.
We've got a wider report that will come to board in June that will give us a complete update of the holistic work around health inequality, both in terms of service users and carers and in terms of our colleagues and staff. So, and that will also, I think, give some proposals around what committees might focus on. So,
That's great. Good to hear.
I think again, an opportunity, with reviewing the strategy. So, we've finished our 2nd year, going to the 3rd. So again, what have we been doing throughout that year as part of the strategy against the domains and our priorities? So, as a lead for clinical strategies, we've been doing a lot there. So can we showcase that when we bring that report to board as well? So again, lots of opportunities there that we can actually showcase what we're doing. So it's visible.
Yes.
Like you said, we'll say we're doing it, but actually, what does that actually mean?
That's really encouraging to hear.
Yeah.
It's really important that we are able to track, monitor, and demonstrate that through our work, we are actually addressing within our gifts to, and then with our system partners as well, because we're not doing this in isolation by ourselves. So thank you for that. That's really reassuring. That brings me quite nicely on. If there's no other questions for Linda to, in terms of the people committee chairs, showing support in patient safety.
No, patient safety report.
Patient safety report. So it's supposed to be more than.
Is it okay if I just get our colleague?
Yes, please.
Like you see this, it's here. Be presenting because the camera doesn't stay right here. And down.
Welcome.
Hello, hi.
Hi, Lisa. It's over to you.
Thank you very much. So I'm quite sure I've taken the paper as read, so I'll just take you through the key executive summary points. So from the top, currently we have 21 live instances in the SI review process. Just to note actually to board that since I wrote this paper, we've actually got 29 live SIs in process at the moment. I've also just noted that whilst the 60-day mandated investigation standard has been removed externally, we should still be working towards that as an organisation. And currently, excuse me, currently we have 8 SIs that are working outside of those timelines. It's important to note, of course, that these are important, excuse me, because obviously timely investigation means timely learning from our perspective as an organisation. So the average timeline for completion of SIs currently is around 90 days, and that is a reduction from the 100-day standard that we identified in January, but as I say, remains significantly over our internal standards. Just to note that the data of serious incidents identifies an upward trend in incidents reported as SIs from January onwards. So in December, we reported just 1 SI, and at the end of March, actually, we reported over 10 SIs. So you can see the continual upward trend month on month. So giving some considerations to what might be impacting that rise in reported SIs, and I've just wanted to kind of cite the board on the reinstatement of the SI Oversight Group, which started in January of this year. And that's a very experienced and multidisciplinary group focusing on incidents. We come together every week, look at the incidents in detail and debate and discuss each element of the incidents. And I do believe that's probably contributed to the increase in those reported as SIs. And so a review of themes and trends from SI reporting in this period indicates a very broad variation in the types of incidents we're reporting. We do obviously see a high number of incidents relating to patient deaths in our community settings and lower levels of inpatient harm, so for example falls resulting in significant harm, for example fractures. However, we are seeing some reported themes from our SIs and some consistency, and these relate specifically to lack of regularly updated risk assessments and care planning documentation, some of our interprofessional communications and referrals between teams, and a lack of professional curiosity at times delaying aspects of care and treatment. And of course, a number of actions are underway to support some of these themes. It has been noted there's a lack of health inequality information submitted as part of our regular reporting to CGC and QPAS in respect to serious incidents, alongside a broader suite of indicators such as our quality metric reporting and our patient experience data. And it has been agreed that quarterly reporting of this data will now be carried out through these formal committee routes. I'm happy to share that in the next Trust Board patient safety report. A deep dive was undertaken in February in the total number of SI actions open as an organisation. The initial review indicated that we had a total of 91 overdue SI actions across the clinical divisions. Again, the importance of this is in relation to learning and into trying to prevent these incidents from happening again. So if we haven't acted in a timely manner, then we have the potential for these incidents to happen again. So a detailed piece of work has been undertaken to look at these historic SI actions, and we have actually reduced this down, taken away duplication and reassigned these actions to appropriate areas, and that has reduced our outstanding actions to 66 across the divisions currently. And from a response perspective, work has been agreed with the patient safety team, clinical governance facilitators and the divisions to review and start to agree timelines for the closure of these SI actions. And we also have a new SI action module on Eclipse that will support the oversight arrangements going forward. We have a really healthy reporting culture as an organisation, so we have between 2,000 and 2,250 incidents reported on a monthly basis. And it's really keen to note to the board that on average 80 to 85% of these incidents are reported as no harm. So a really healthy reporting culture. A deep dive of open local incident investigations was also undertaken in January, and we looked at all incidents on the Eclipse system since the system was integrated in 2011. What we found was that we had a total of 4,535 incidents open on our system. Furthermore, 82 to 85% of these incidents were overdue for action, with 16% of these predating 2022. And it's a similar story in that if we don't close a review incidents in a timely manner at local level, we miss that opportunity really to learn as an organisation. So a methodology and approach for the safe closure of these historic incidents was submitted and agreed by the Chief Nurse and shared through QPESC last month. And a timeline for action has been agreed for this work. And with that timeline, we anticipate all historic incidents up to 2023 will be safely closed by the end of May this year. Thematic reviews and work with divisions will be undertaken to ensure that we don't lose any opportunity for wider learning in response to these historic incidents. The paper also draws attention to the recently concluded and published external niche reviews following 2 historical domestic homicide incidents occurring in 2014 and an independent multi-agency review on behalf of the statutory services involved into the care and treatment and management of a service user who sadly committed 3 stabbings in Birmingham City Centre in September 2020. Work is now underway with the relevant divisional stakeholders to action these recommendations from the reviews. And just to cite the board that we have all, NHSE have also recently commissioned a new review by Psychological Approaches following a homicide which occurred in 2018. And this has a specific focus on access to AMP services, how we listen to relatives as part of our assessments, and Regulation 28 report requirements. There have been some areas of required improvement identified in how we respond as an organisation and monitor ongoing actions from external reviews. And improvement of this will be supported through devising a formal policy and improving our internal oversight processes, including our committee reporting. The paper also draws attention to a recent Regulation 28 ruling issued to the Trust and other health organisations with the Birmingham Solihull Integrated Care System. A collaborative response is being facilitated by the ICB, and issues highlighted specifically for our organisation include access to PDU beds, safe spaces in ED, and consideration of a multi-agency protocol for informed missing patients. And so we're working collaboratively on that response currently. Again, there have been some areas of required improvement identified in how the organisation responds to and monitors ongoing actions from PFDs. And similarly to external reviews, improvement will be supported with devising a formal policy on this and improving the internal process of monitoring and committee reporting. For the board, I've given a brief review of the implementation of the new Patient Safety Incident Report Framework. We are in a really positive position as a trust in relation to our preparations and our transition phasing, which is really positive. The paper does draw attention to a number of decisions that will be required from the board over the coming months in relation to PSERV, specifically around organisational training, testing of the organisation's safety climate, and consideration and agreement of oversight arrangements as the lead provider of the provider collaborative. In line with the move towards PSERV, the PSERV way of working, the paper also discusses a new process that we've devised to support wards and services where intelligence indicates safety or quality concerns. And this approach is defined as a safety summit And broadly, this is a framework that encompasses a review of specific data sets that give us a kind of overarching and holistic view of how that service and ward are running. And this review is undertaken with all key stakeholders of the ward and service areas and management team and the corporate services that may be able to support them in taking some of this work forward. It was reported through QPESC in January that a deep dive review of open complaints cases revealed that 61% of our cases were awaiting the investigating officer. Furthermore, some complaints had been waiting up to 4 months to have an IO allocated to them. I'm pleased to report to the board that following considerable work in this area, during the month of February, these numbers have been reduced to 38% awaiting an IO. And we've also had additional temporary resource allocated to the team to reduce that further. Data does currently evidence that the average length of time taken to investigate complaints is between 75 and 81 days. And we do recognise the complexity of our current complaints, but it is proposed that this is not in line with best practice standards for our patients and for their relatives. It is anticipated, though, that in managing the historic backlog, we will bring that significantly back in line with timelines that are so much better. There has been limited work to date undertaken around thematic reviews of complaints and learning to date. And a comprehensive review of this will be included in the report for April's QPESC. This will enable the committee to be cited on the last 6 months of complaint data, what the learning has been and the impact of the complaints. And also contained within this review will be the health and quality data that's so essential to get that all-round picture. We have had one formal PHSO and one formal CPC complaint raised in this reporting period, and these both relate to Section 117 aftercare arrangements. Actions taken include team training and development, and work through the provider collaborative has been agreed as a response. And just finally, a deep dive on outstanding actions from complaints was also undertaken during January, and it was evidence that the organisation has a total of 36 complaints actions open currently, and furthermore that 84% of these complaint actions are currently overdue for completion, with some actions being over 18 months old. Reasons for this have been multifactorial. So looking at it, I think the reporting centrally to divisions is not as transparent and effective as it needs to be. And we just need to improve some of our internal processes around monitoring of them and supporting the divisions to close these. So work is underway to address this with the complaints team and the team working collaboratively with divisions and our clinical governance facilitators to close down these outstanding overdue actions. I haven't yet established a timescale for this piece of work, but anticipate to be able to do that in the coming weeks. And so those are the key items. Thank you. Happy to take any questions from the board.
Thank you, Lisa. Are there any questions for Lisa?
Can I just start by saying I'm quite important? Very easy to read, and it's got all the key aspects that we require, so really good. Having said that, there must be questions. It's kind of explaining things, so that's what's important.
Yes.
In terms of the themes, I thought there were some really interesting things coming through.
Yes.
And I was just wondering what were the sort of actions that relates to the ones that I'm particularly interested in. I think one of the phrases really interesting. I can't find it now. Where it talks about a lack of curiosity, professional curiosity.
Yeah.
That's a bit of a reason to be, but I was just wondering what are the sorts of actions that you put in place to address that kind of issue, if they're resulting in serious incidents, because that sounds, I see things that sound serious to me. That as a phrase seems sort of quite a light description of something. So I just wanted to balance that kind of thinking out both ways.
Yeah, and I think it's probably key to say that the professional curiosity element has been more of a contributory factor to an SI as opposed to a definitive root cause. And in response to the actions being taken, those are varied because it really depends on the service and the SI. So I can give you an example of one of the things that we're undertaking at the moment is in some of the SIs related to our areas with mother and babies. We've identified this is as a kind of underlying theme, and so we're actually meeting with the area leads, with the service leads, to look through this in more detail and look at how we can support it. So some of these actions can be around a lack of training and development, for example, and some of it can be due to inexperience in the team. So if you've had experienced members move on, you're dealing with a very inexperienced team. So there are a combination of actions that we can take, but it's very dependent on the service itself. But the approach that we've started with the safety summits and looking at this in more detail and meeting with services really enables that deeper thinking and enables to take some of those actions. I know that's quite a broad answer.
No, it's actually, that's a really good answer. Okay, because it's about a more strategic response to something that's quite slightly intangible, but actually has a significant impact and therefore needs thinking about in a broad sense. So, right, thank you very much. That's reassuring. That's really
Thank you. I'm going to just go through Sheena and Bella.
Just a couple of things. So I wanted to thank you personally for the lens through which you looked at our patient safety issues and children trust and you've with us for a short period of time. And I think the lens that you looked through has been really helpful in thinking about the so what.
Yes.
So I think the report really brings out some of the so what does this mean for us. And it really helps us understand where improvement can be made. And rather than sometimes getting lost in the data. So I think that's getting that balance right has really come through in the report. So I'm really clear around some of the areas that we need to focus on. And maybe some learning about how we ended up here, which maybe doesn't identify, but I think would be helpful for us to ensure we don't go there again.
Yes.
And then the other thing was just for some further information. So the homicide review pieces that you talked about, the niche reports into the stabbings that were undertaken is due for publication in June.
Yes, that's right.
And the board will remember that we were one of 13 organisations who were involved in that review work. And we offered very early on the opportunity for families, if they wanted to take it up, to meet with them. Steve and I are meeting with 2 of the families involved in that in advance of the report, so next week, in fact, to have some discussions with them. So then may well be more that we can bring back above and beyond what the report might tell us by having those conversations with them directly.
That's good. Thanks, Rasheen. Bella?
Yeah, no, thank you very much for the report. Really clear on that. Just a couple of things, maybe just to clear in my mind. The PISA framework then
Yes.
will change the way we do things and make things better going forward. Is that right?
Yes, it completely changes the way we look at incidents. So we won't be reporting anymore on just on serious incidents. We look at incidents more as a system within the hospital and the way we approach it and the way we review. There's a whole change in that, and it's going to be massive actually for us in organisations, and all of us are really welcoming of it, but probably slightly nervous because we've got used to working a very specific way. But it's much more engaging, less blameful, and much more about a systems approach to how we understand incidents.
So leads me on to my question then. Just in terms of assurance of, has this framework been used somewhere else to sort of say, well, you know, it's worked here, therefore, you know, if we adopt it here in Solihull, that we've got some assurance that things will definitely be this. We don't necessarily want to have this conversation this time next year per se, but then also what Yeah, on that question, is just in terms of the assurance, and then I'll remember what my second question was.
Nationally, there's been a series of early adopters, they're called, who have tested and tried this framework, and those are the organisations that we're learning from really, and but there's specific forums nationally that you can join, where the early adopters share their experience with their challenges, things that went well, things that didn't go so well, and overall feedback is massively positive. I was explaining to our chief nurse that it won't change the workload actually that we have, it's just that we're doing it in a very different way.
I do remember my second question. This is an absolutely key piece of work. So to support the fact we need to do this. You referenced that you're going to have to come back to the board. There's going to be some decisions that we need to make. Can you give us some examples of what those decisions might look like, and what potentially the impact could be? It could be financial, could be whatever that looks like. So we want to start to prepare ourselves really, I guess.
Yes. So one of the key issues that we need to decide as an organisation is how we want to train the organisation from board through to at all levels on PSERF and the principles around PSERF, and how we investigate incidents going forward. There's a number of ways that we can do that. We can do that through the HSIB online learning, which is everybody would have to sign up and look at it and train to a specific level. Or we could take the approach that other organisations have, where you actually, for example, bring in external experts, for example, to do a board development session or to then understand your key responsibilities, and then take a different approach with the rest of the organisation. There's lots of different ways that we can do this, and an options appraisal is being prepared to kind of give you the thoughts around how you might want to proceed with this. I think I cited the execs actually on a brief session last week that these specialists that are coming in now can cost upwards of £20,000 to train a board. So it's quite a considered a thought process really. So that's one of the key decisions. And obviously as we move through into so part of PSERF is adapting our the way that we respond to incidents based on the organisational climate and based on the safety climate within an organisation. And whilst I recognise we have elements such as the the staff survey example, for example, we can take elements of safety climate from that. We haven't had a specific review of what the safety climate is within our organisation. And again, there are a number of ways that we can do that, that will vary in cost and varying how much we get, how much detail we get as an organisation. So again, we'll be presenting that as an options appraisal for you to consider, but it is an absolute integral part of PSERF moving forward. And then the other thing to look at is, of course, that we will be looking at how we assure ourselves as an organisation around our implementation of PSERF and our learning from PSERF. But as the lead provider, Provider Collaborative, it's just consideration of how we get that assurance from our other organisations.
Thank you.
Thank you. Thank you.
I just want to add, this thing where you talk about collaboration with traditions, I think that's really positive, but it resonates with what you see elsewhere, that there's an awful lot of asks from corporate to service leaders, and I think at times it feels like it's an impossible ask. And I just wonder, it'd be really useful to understand from the operations leaders how realistic it is, because the danger is we'll look at it from different perspectives and ask them to do. They've got to work out how to do the other things. And it's not necessarily in this just in isolation. That's really, really useful to understand how we reconcile that. Because you've got really competing demands to do this, limited resources, they're trying to do the data job. It's just really understand that, because there's no point, I don't think, having a process in place isn't sustainable.
Yeah, I mean, it's a good question, Dave, and I was just going to ask Lisa just to reflect on the conversation we had at committee around the infrastructure.
Yes.
And, you know, this, we do a duo on this because we've got a governance structure that sits in the divisions, which needed some refining. There has been some gaps there, hasn't there, around, you know, around staff. So how do we broaden that? How do we strengthen that? Because, you know, we're really clear that this work needs to be done as close to frontline as possible. There's no point in it being duplicated. It needs to be there. It needs to be owned. People need to be accountable. We've got clinical directors, social directors, you know, a really sort of multidisciplinary workforce. So that was my question to yourself. Is that working? And do we need to strengthen it more? Which will probably answer a bit of Dave's question as well. So there's an infrastructure there, I think is a bit of an answer, Dave. Do we need to do more to it? And can we help and support around that?
If you have me to respond, yeah, I do think there's probably some improvements we can make in regards to our local governance arrangement. And one of the things that Dave has spoken to me about is doing a kind of desktop exercise to look at our arrangements at local governance level. And also just to note that from kind of PISA implementation, the plan is to drop corporate services into the division. So each division will have a patient safety lead, a QI lead, a patient safety engagement partner. So you'll have that kind of core group of individuals sitting within your divisions, focusing on your divisions and to take this work forward. But I believe that's better than having them completely.
Absolutely, yeah, and that kind of answers Dave's question a bit there around obviously making sure it's sustainable, isn't it? Absolutely. You know, because again, sort of, when it can't put different classes, it needs to be a really robust team to support and enable going forward.
It does, and I must say from the SI oversight group that your divisional leads are amazingly engaged, and the challenge of each other in those forums has been amazing to see. Actually, supportive challenge, but nonetheless, you know, that peer-to-peer review and support. So they're very engaged, I think, at divisional level into making these changes.
Yeah.
Excellent. Patrick and then David.
Yeah, I just wanted to make a point around something that was cited in this report from QPAS on the gap in assurance and capturing complaints, capturing CQC, and it's really good to see in your report bringing that assurance that's been resolved and immediately. So to reflect on that and see the committee report and get
David and Linda.
Yeah, thank you very much, Chair. I think one of the other elements which Lisa and myself have discussed has been the idea of reviewing our current governance arrangement from ward to ward and see where the gaps are, and looking at elements around standardization. For example, comparing agendas and how they are there and the rest of the stuff. Picking on that and seeing where we can make improvement and do the strengthening, and getting a lot of clinical engagement and involvement in PISA will be very critical. The sustainability and embedding it going forward. But one of the other things I wanted to reflect on is the fact that, excuse me, this piece of work emerged from the CQC well-led review, which took place a few months ago, when they raised the fact that the board did not have oversight of the instant reporting of some of these. So around the safety. So we just thought that this report needs to come here. So it'll be very important for the board to make a decision going forward if this we would like to have this regularly on their menu.
Yeah, I think it's definitely something to reflect on. I'm sure we're not going to say no. We're just going to actually just discuss how and when, the frequency.
Yeah, I suppose it's a similar, it's a reflection in terms of when we think about incidents, all healthcare organisations have incidents. It's what differentiates them is how you respond to them, and it is quite linked into some of our values actually driving us as an organisation. Is this new approach is about changing culture and behaviour, and there is something about us understanding that complexity is a board and thinking about how you allow your staff, your divisions to sort of have that curiosity to approach incidents with compassion and not blame, but at the same time you know, allowing decisions to be made that may stop us collecting certain types of data that focus on others. So, you know, you can reduce some of the demand on their time by allowing that sort of progress in terms of how we move forward with this approach. It is potentially going to be initially while we get a head around it, but actually it will release time over time, if that makes sense.
Final comment, Vincent?
Well, it's not comment, it's actually, just boils back to a couple of things in the report which stood out for me. The first was the average amount of time for completion of an investigation being 90 days. So you indicated that's not really where we ought to be. It'd be interesting to know where we should be on that, and potentially through Keep as a plan towards us getting there, and whether that requires more resources. The second instance, again, relating to timing, was related to the complaint side of things, and it quotes some complainants waiting up to 4 months to have an investigating officer allocated to them. And I'm thinking of this from don't know the nature of the complaint, but it could be from a service user, it could be from a family, or it could be, and I think that if you were in that situation, it wouldn't really be acceptable. So I'm pleased that we've got an additional resource to do that, to support that. And I'd just like to know again what reasonable amount of time ought to be from your experience, your opinion. And then the other timing one again is data continues to evidence that the average length of time taken to investigate complaints is between 75 to 81 days. So again, that's an area that we also need to. So it'd be interesting to know, because you indicated not where it should be, but what kind of number of days do you think those ought to be? What should we be aiming for as a trust?
Yeah, so I take SIs first. So we always had a national mandated standard of investigating SIs within 60 days. That allows enough time for a robust investigation, but is timely enough to ensure that we're learning as an organisation in a fairly rapid way. So that is the standard, and of course that was removed during the COVID pandemic for a number of external reasons. But as trusts, we should maintain that standard internally, because as I've just said, if we let it go over that time, we start to be at risk of another incident of this type happening. So it is a good question about the resource. I think that what you can see from the report is that actually our number of overdue incidents are reducing, so that will reduce the average time that I'm reporting on. So I think going forward in the next few months, this will be an area of review from a resource perspective, because we are also seeing an increasing number of SIs being reported, so that will be an extra burden on the team at the moment. But I think we need to let that play through and see the impact of that. In regards to complaints, so I think this is the first time, certainly alongside the team, we've really looked at this data in detail. I am confident with the additional resource that's been enabled by the chief nurse that we should be rapidly bringing that awaiting investigating officer right down to the kind of 5 to 10% margin. And certainly they shouldn't be waiting more than a week to 2 weeks, ideally, before they have an investigating officer appointed to them. The timelines of our policy needs to be reviewed, and the complaints policy is under review at the moment, because our policy currently states we can have up to 6 months to review a complaint. Actually, that's the PHSO deadline. Now, we shouldn't be wanting to get to that deadline when we're investigating complaints. And normally, the normal amount of time we would take is anything between 4 to 6 weeks to do a robust complaints investigation. So that's the target level I'll be working with the team to achieve.
Thank you very much as well, because the fact that you brought these things out of your report has enabled us to ask these detailed, searching and challenging questions to the organisation. Thanks very much.
Lisa, thank you. It's been a really, really productive discussion that we've had. Really helpful report, very clear, very concise, and very welcome by all. I look forward to receiving the options papers, which is coming to the board.
Yes, we're working through those. It will be soon, and hopefully they'll be completed by the end of April. Yes.
Thank you.
Thank you
Thanks
very
again.
much.
Thank you.
Continuing on, Nicole,
Yeah, okay, thank you very much. Over the 2 meetings that we're talking about in March, February, March, I chaired one, Monica chairs another, so, just bear that in mind. So I'm bringing the two together. I'm taking the report with red, but I'll just pick out some of the key highlight areas. I think it's important to say we are trying to run the people committee as an important part of understanding how we're improving the lives of the people that we work with, our colleagues, and therefore a lot of the questions that we're asking are in that context quite a lot of the time. And so as a result of that kind of approach, we agreed that we're going to have a regular colleague story at the beginning of each of the meetings, and perhaps also invite the networks to come talk to us, and also perhaps the unions. So the people that are really representing our colleagues across the organisation, just to kind of get that real feel and give the meeting in the right context. And we've also, following some challenge, agreed that we should consider a review of language that we use, because actually we use different sorts of language for different things. Sometimes we use BMV, sometimes we use BAME, sometimes, a whole variety of things. Sometimes we get the plus of LGBTQ plus, there's a whole variety of things. But obviously not to sit there and decide for ourselves, but actually to go to the networks in that conversation. So they help us identify what language we should be using, and trying to run that through the organisation the best that we can. There's been a lot of work. There was the first meeting, February meeting, was a deep dive into well-being, and obviously that's kind of what we're trying to really focus on, all of our aspects of our work around actually how we do this well-being for our colleagues. And obviously there's a lot of work going on. It was really great to hear about that, but really we want to know about impacts. We want to understand what the safety is, what the impact is, and understanding that. And so that we've asked the people directorate to kind of take that forward. In terms of workforce transformation, we received a really good presentation around the process that the organisation is going through into developing a workforce plan, which was felt very thorough and most importantly engaged a couple of colleagues around the organisation in relation to its development. Again, we'll see what the outcome of that is, and I think it's this next month. We're going to be seeing that, so that nodding at the end. So important to see and be able to see that engaging through the presentation there. In terms of key risks, clearly workforce vacancies and safer staffing and kind of is the thing that's kind of front and centre around a lot of things. And we can see there's an enormous amount of work going on. And I attended the safer staffing group to observe, how the conversation is had amongst the key team members. And what I would want to say formally here is, to express my thanks, and I'm sure the thanks of the board, to some of the senior nurses who are doing, ordinarily doing a management role, who are now also helping to cover shifts. That's quite a significant thing for them to be doing, and they're working really hard. It's very challenging, and how pleasing it was to hear how the multidisciplinary team was working together to make sure that wards are safe and services are safe, where there might be risks that are, occur through the process. So that was really heartening to hear that people talk about that readily and easily in conversations. Having said that, what it also identified was a number of key areas we've got some work to do, and I'm going to be meeting with Vanessa Rice and Steve to have a conversation about some of those key issues so that we can get a report through to committee in relation to some of those key areas, particularly around wellbeing of colleagues. In terms of other performance, although some of our KPIs are kind of going in the right direction, and I know Roshi refers to sickness, reduction in our sickness absence rate. What's clear is that some of the other indicators aren't kind of getting to the place we want them to, and often they are the ones that are about providing value for people, so appraisal rates, rostering system, making sure that people feel valued and engaged in their daily work. And so it's important, and it's good to see again in your report that there's a real push to get some of those things in the right place. But I think we'll continue to be working through that again with colleagues. We did receive the what's called the gender pay report, and we'll come back to that later because it covers other areas also, and the RES report. So I won't go into those in any detail because we're picking them up later. We did note we had a report from the subcommittees and noted that the progress is pretty good in relation to delivering the key requirements of those that fit across the things I've spoken of before. But as a result of that, there's a review of the goals themselves of being undertaken at the moment, which I think is just to keep the momentum going, get us, make sure that we don't lose ourselves in self-satisfaction and make sure that we're working it through that process. We had a report from the Freedom to Speak Up Guardian, and what was reported was a fourfold increase in the number of Freedom to Speak Up issues identified, which on the face of it, you could feel worried about, but actually it's actually a really good sign that we're starting to open up the conversation with our colleagues and they're feeling comfortable to raise it through the system. What we need to do now is make sure that we can deliver on that from the system side. So when people raise issues, we are able to respond effectively within a reasonable amount of time. And of course, people, if they've raised an issue, it can make them quite anxious, regardless of what process they've gone through. So waiting a long time to have a response to that can be quite daunting for them personally. So I think I would encourage the approach we talked about a little earlier to kind of get those more rapid responses in the system of whatever we need to do. And that's our role as a board and exec colleagues and senior colleagues to be able to get that in motion now that people are raising issues as we've asked them to. This is responding to that. And finally, just as a formal process, we formally agreed terms of reference and the forward plan, although I know we've already changed it once since we approved it. So apologies, David, if we didn't follow the rules effectively there. But so we formally approved that. So that's my report. So if Patrick, you want to add anything to that?
I think that's comprehensive, but I think it's helpful that we have a schedule of deep dives that at the committee which enables us to have the space to be able to have robust conversations in terms of our wicked issues. And also I welcome the fact that we want to encourage networks to come and share stories about what it's like to work in this organisation and what we can do more of as a committee and as a board to improve the experience of colleagues. So I think that's all I can add.
Thank you, Patrick.
Are there any questions for Anne or Patrick?
Just a question, more comment to be honest. I really did appreciate what we're doing in relation to staff wellbeing. And I think later on in the agenda, there's going to hear the staff survey report, which is quite, it's not exactly an uplifting report, but I think actually some of the things we're doing in staff wellbeing, we ought to promote more as a board and as an organisation to kind of counter the notion of that, this organisation may not be the best place that people may wish to work, because I think some of the things that we're doing here would actually possibly attract people to work in this organisation. So that was a comment. I also noted that on sickness-wise, and I think it was referred to in the machines report, but I think we've got to acknowledge what ICCR are doing in relation to reducing their sickness rates as well. I think that's quite commendable. And I think let's just make sure they're recognised for that. And I'll encourage other directorates to reach where they are as well.
Yes, definitely. Thank you, Winston. On the back of that, can I just clarify, because those come up in the finance report, in terms of ICCR, they utilise their use of agency significant in relation to staffing, computer science staff. I just wanted to get an understanding of why that is the case. Is it consultant?
Yeah,
Is it?
yeah.
Talking about the rock, yes.
Yeah, there's particular gaps in our community mental health teams. So we have consultants and in SOVA who some agency staff who are embedded in the teams at the moment. Looking at the job description, looking at particularly the caseloads that the teams hold, because that is putting people off applying for the roles because it's a big caseload that a psychiatrist would have to hold. And again, this is where the community transformation comes in, with people who are in our services that could be supported better in primary care, so therefore the caseloads reduced. So Sadira Derry, one of our clinical directors, is absolutely leading this work going forward. We've also agreed to have clinical leads in the directorate, specifically overlooking the hubs, to put again some more sort of clinical leadership in there, with more sort of time to help and to work the plan through. But yeah, it has been noted. There's a plan, particularly around. I can see Phil Giles, and Giles is our sort of guru around working with the clinical directors around that recruitment. So we've had some success in some of the areas.
Yeah, definitely. So I think it's definitely a challenge. I think that's the difficulty, but I'm hopeful that the transformation will be really helpful to make the jobs more attractive so that people can recruit into it. But unfortunately, it's a national difficulty. We don't have enough consultant psychiatrists, and specifically nationally, it's the community mental health team which is so difficult to recruit into. But hopefully, the transformation will make it a more attractive job, as well as actually meeting the needs of our patients. So hopefully, it's a bit of a win-win. But we're just not there yet. And so what we've got really at the moment is almost like a double cover of it. So that's why we've got such a lot of agency staff coming in. Hopefully we'll be able to transition out.
We've got some additional resourcing as well to help that transition. That's Sadira and Elaine sort of built the business case around how that would work. So we can look at caseloads and how we can reduce caseloads. So again, a plan and train around that. But yeah, very, very mindful of the cost pressures there at this moment in time.
Apologies as well, using acronyms for those who might not be familiar with them. ICCR, community care, sorry. So my colleague, recovery. So my colleague Anne just from my point. So if we can be mindful of that in terms of the acronyms that we're using. I just also wanted to reflect on the points that both Anne and Patrick made, which I'm really encouraged to hear that we're actually going to be including more our sort of staff networks, actually bringing them, whether that's quarterly, twice a year, or whatever, to the people committee. And also our staff side in unions, we did reach out to them myself last year, had a couple of meetings with them, and actually did raise that was our intention to invite them along. We did get the reports from JCC, we get the JCC that goes to people committee, but I think just actually saying we value, and also we want to hear as well, some of the themes that we are actually coming across with our colleagues who are engaging, who've got concerns, who are raising concerns, and just find them in. There won't be members, but maybe, once or twice a year. So, welcome that.
Yeah, just a question for Anne, I think, really. So it relates to the insurance report from February, and it's the first item around quarterly performance indicators. And there's a statement in the insurance comments around the committee being partially assured on the work that was underway, but asked that there was a clearer journey to improvement rather than a target achievement to be demonstrated. And I just wondered what we can expect to see as a consequence of that ask.
Yeah, so what we've been talking about, in fact, we've been talking about in a number of different committees actually, is actually provided, because actually the delivery of some of these targets is challenging, I'll put it that way, it's very challenging. And actually constantly saying, how are we going to hit the target is sometimes impacting on discussion or the kind of feeling, the debate of the discussion. And so what we've been talking about is what are the steps on the way there, so what's the improvement that's occurring over time? What can we expect to see change? It might not always be in the numbers, it might be in the process initially. It might be, and so having a conversation about what we're going to do, make this change in the process, that's the first thing, but we won't change the numbers, you'll expect to see the same numbers. Then having done the process and having that conversation that focuses on the actions that people are taking to make improvement, it's a much more positive conversation in the committee, and it's also providing assurance to us that actions are being taken in a timely way, that we're, you know, and we're clear that the people have got, and I hate this word, but I'll use it, grip, that they know what needs to happen to make a change, or a change to deliver the day that you say it's going to happen. You have to do things to get there. So it just creates a more positive conversation in committee, because some of the targets, vacancies is the classic example, is, you know, will take time. Once you've recruited people, it takes them months to come in. So you don't see it for some months later, but you can see that those changes happen. So trying to have that kind of conversation. But that's what I'm hoping will happen in terms of the reports from now on.
That's helpful. It helps clarify what it means and also brings to life what we do expect.
Brilliant. Thank you, thanks. If there are no further questions, then we're going to move to the Finance, Performance and Productivity Committee and reassurance. Thank you.
Thank you very much. I'll take it, everybody's read the papers, so I'll summarise from a perspective of our sort of three aspects really: our financial plan, performance, and our capital position. And I'll just cover off some of the other items of relevance as well. Just in terms of our financial position, our trajectory coming to the year end, we will be breaking even. We've had a positive discussion about all the various activities that have taken place to actually get us there. I guess the challenge for me, and this is my sort of first and second chair of the committee, was really, you know, how do we get greater assurance to the year end much earlier on in the year, so that we don't have that sort of volatility around sort of the last quarter of the year. And I think that's the challenge to the team in terms of how we develop our plans and how we make them more robust going forward. The challenge going into the next financial year is quite substantial. You know, we're posting an £8 million deficit, and clearly that's going to be a huge challenge in terms of how we address that. And I'll come on to some of the conversations that we've had around that. Just to give you a view on the significance of that. As a system, it's around about 120 million. So 8 million is our contribution towards that.
Just on that,
Yeah.
there is an update on that, just so
Yeah.
we pick up how that's changed.
No, that'd be brilliant.
You're talking about at the good signs.
Yeah. So this is as of March of this financial year, and Dave, I'm sure will update us on that. It is a dynamic plan, and things will change and move as we collaborate and move forward on some of our ideas in terms of how we're going to build a much more robust plans to underpin that cost position going forward. The biggest, I think it's an opportunity here and also a challenge. It's quite clear that our current way of operating in terms of cost improvement programs, whilst it's sustainable to a point, it's not sustainable for the long run. And I think that the challenge that we've put to the committee is how do we look at it through a much broader lens? And Vanessa talked about, you know, all the collaboration that we do around the system working, how we're looking to see how we may reset the way we offer some of our services. to our patients. We need to look at that in the context of what we're also doing in terms of our strategy. So how does our strategy then influence our programme of transformation going forward? And how does that then all contribute to delivering potentially a financial headroom that will then give us the sort of the financial assurance that we are sustainable going forward. But like I say, 8 million is a huge number, and we shouldn't underestimate the challenges that we've got. So that sort of transformation agenda is really important and how we bring that to the table. And I know we've had meetings with Vanessa, with Patrick, around developing that plan, and hopefully over the next couple of months, as the strategy will be presented to the board, I think it's in June, we'll hopefully start to see the germinations of that plan, and we can then look to see what elements of that is contributing to give us the right level of financial opportunity going forward. So that was on our financial position. In terms of our performance, our key challenges remain sort of consistent around our out of area bed placements, temporary staffing around agency and bank, and our dependency on recurring cost savings. So going back to our financial position, one of the opportunities we really need to leverage is recurrent cost saving opportunities, and not necessarily rely on non-recurring cost savings. But that again in itself it presents itself as a huge challenge. In February we looked at our plans around performance, and we asked if obviously on the basis of the people committee did look at our future trajectories around what Get Well plans are actually going to deliver, and how when we're going to start to see benefits come through. And so in March, that position was much clearer, and it was really good to see when those trajectories and when we're going to see an upturn in performance on all of those areas. And that's important from many fronts, not just in terms of having a much more robust conversation at committee, but I think it's very important for the people working on these projects that if you're continually doing things that aren't really necessarily making an impact or an influence, then it can be quite demoralising, as a workforce. So I think it helps us to help them to have those conversations to say, well, okay, if we're not having an impact, what else do we need to do? And how can this board or how can this committee help leverage some other way of actually addressing that same problem? So that's again that's the challenge that we're sort of facing going forward around performance. Our capital position, again, if you look at our financial position across the system, capital. I think for next year, I think our capital request was for 7 million. To be honest, Dave, and that in itself, if you look at the size of our trust and the size of opportunities that we may want to leverage strategically, we're just going to have to work out whether that's going to be sufficient to actually help leverage some of the sort of future development that we need to put in place to really take us forward beyond next year. So that challenge will continue. But I think also we need to, as a trust, look at other opportunities where we can potentially access funds and capital spend maybe through government funding or third sector opportunities. So we just need to look a little bit more broader than perhaps we are at the moment, from a system perspective. So I think again there's some opportunities there. But I think importantly, if there are opportunities to leverage more capital funding from other sources, as a team, we need to have some of those business cases ready and waiting, so that we can actually then sort of jump onto the opportunity and sort of be able to grasp those opportunities in terms of if it's a bid or whatever that might look like. So that's our position on capital. In March, finally, we also had the opportunity to review the Trust's green plan or strategy around plan for the decarbonisation. A really great presentation, which assured us that in terms of the building blocks that we've got around some of the obvious areas that we need to focus in on, around electricity, gas usage, our fleets, and our waste management. Again, the challenge to the team was, where are some of those opportunities around developing our cultural shift change in terms of people's mindsets and behaviours, just around, for instance, switching the light off when people go home or when they leave the building at the end. So I think, some of the work that we're doing is great. I think there's a whole cultural agenda that needs to be developed to really then make it sort of self-sustaining, really. So that's the challenge on the green agenda.
And I just add on that.
Yes, of course.
We were hoping to bring it to today, the update around the green plan. For a number of reasons, it's not here, and it's going to be due before the next board meeting. So what I suggested to Winston, we can circulate outside of the meeting, so we can see what we're doing in advance, so we can just try and move that public service danger. Now, when we're waiting 2 months for something to come through, it slows it down. So we're trying to do that publicly outside of them. I think point's really well made. It's some things you do things against the target. It's what you try and do around the other things as well.
Yeah. So I think just in summary, the whole piece from a strategy perspective, from a transformation perspective, needs to be pulled together, and how that then it sort of underpins our financial headroom going forward. It's a huge challenge. I don't think we should underestimate how big that challenge is. And I think that's it from me, unless Dave.
I'll build it on the report. Follow on from this.
Sure.
Thank you. Thanks. Are there any questions?
There's just a couple of things I wanted to comment on. One was about the transformation agenda, because I think if you recognise for some time that that's where we need to focus, that traditional way of creating efficiencies, we need to be transforming because we need to be sustainable anyway, in terms of delivering services to people that matter. But also to try and, as a byproduct, think about what does that mean in terms of efficiency. So really welcome, particularly your expertise in helping us thinking about where we might do more of that, because we know we've exhausted some of the, we know that we're already ahead digitally. Amongst other trusts, we know we're ahead from a state's rationalisation point of view, which are the places that most people go. So really welcome that. And to also say that obviously as a Birmingham Solihull sister, we're also thinking of that through in terms of what are the items that we might, or the pathways of care, or the professional services that we've got that support us, that we can do more collectively that could lead to some greater efficiency. So just wanted to point out that we are thinking about in that context as well. And then I just wanted to comment on capital, because I think this is really crucial to us, and not just us. I think the NHS more generally. I think it is interesting that the Judicial Review report is going to make reference to it, because it's something I think that most people mentioned. So from our point of view, we've got what I would call a sort of bit of a double whammy when it comes to how we might provide the best care we can, that includes reducing out of their replacements. Is that we've got land that we can use, and we know that we've got potential to do it, but the capital element is difficult. We've got quite a significant reliance on the independent sector, which doesn't create the flexibility, doesn't create the financial value for money that we want, and it doesn't create the right level of safety and quality culture that we want either. We are in the process at the moment of looking at our alternatives, as you know, but we're also going to be escalating to our regional and national colleagues our concern from a system point of view around the level of risk that we've got around being able to reduce that out-of-bed replacement without some support to think differently about how we can go and access capital. So we're really pleased that our system colleagues are saying that any capital that's coming to the system provision to us to provide mental health inpatient provisioning would be the priority, which hasn't been the case in the past. But I think that alone isn't really enough. We're going to need some additional support to think differently about capital. I get your point about what are the other avenues, but even some of those avenues, it will still count for us. So we do need to be able to continue to use our influence and to pressure.
The constraint actions to Treasury only allows so whichever resource you go, whether it's local authority, whatever, or alone, it's constrained. And then we think about how to make sure this works. So it's up to any agent, NHS organisation right now, it's not enough capital. We've got particular huge big instruments, but until something changes nationally, it's really difficult. Drop me,
And you're actually right. You're actually right, Rashid. It's it goes back to that point. I guess everybody understands the constraints that the NHS is operating under. It goes back to the point about those get well plans. I think we need to get conversations to a point where we actually absolutely identify and understand what that position is. You can't take something forward, if it's capped or it's the only constraint, we need extra beds, physically need extra beds, then I think we need to be very, very clear to the system that is where we've got to, and we are doing that. I'm absolutely sure that we're doing that. But I think we just need to have those real sort of robust conversations because we can't keep fooling ourselves that sort of a continuous improvement program will fix it.
Certainly agree, and go with what Sheen was saying earlier in terms of as a system, and also in terms of collaboration with back office as well, and how that we can work together to actually drive efficiency. I do believe, I think that in the Hewitt report, whether it's going to make any difference or not, but there is a recommendation for Cabinet Office to have a health improvement division, and maybe that can help in terms of capital, because obviously it was linked or that. Whether that's actually taken on board and implemented is another story. But there's huge challenges that are making massive challenges going forward for the system as a whole, but also particularly for this trust. And we are creaking, and we've got some sites that really do need that investment, so that we can improve the services for our patients, but also we can bring those individuals who are out of area back into back to this area.
And if I may just check one point, Chair, I've not read the Hewitt report, but all the summaries that I've read doesn't reference social care, which was one of the biggest promises the government made. I don't want to make it a part of political conversation, but that is very fundamental in terms of the success of how we can be successful.
Just one comment. So in your February update, there was a review of the terms of reference was the mark of the committee. I noticed that in your insurance comments, the two key things that I did put in insurance comments. The first thing was reference to the financial strategy. I guess we're getting to that is the need for the trust to refresh one, to have one. And the second bit is an investment strategy, which seems to be loosely reference to the budget setting. No, sorry. As the placement of cash balances as well. So that suggests that we just need to do
it was language, it was just sharpening up the language. And one of the first things I looked at the terms of reference, and I asked David, so, well, can you show me the financial strategy? And I think it's just it's what you might class as a financial strategy. Right. I think if we say financial strategy, well, what is our financial strategy? I think it's a fair challenge to drive that in that context, and I think it is important rather than having to. I think it's financial can't remember what the wording was, but you know, I think we do definitely need a financial strategy.
I think, yeah. And then the other bit about terms of reference that you highlighted was a challenge to the committees leading on the lines of monitoring of controls and assurance sustainability sections of the and was also that other committees and areas of government structure with a role responsible for protection. I wasn't sure what you meant by that.
So just to clarify on that, so we've got as part of the finance and performance committee, the sustainability areas of risk that currently are identified. Given that we've got an £8 million challenge next financial year, we need to have somewhere that visibility that is a risk to the trust. And I think that was the conversation David and I had through the committee to actually then just sharpen that view. I think we do need to have that visibility as well as all the other sustainability challenges.
I think something like that comes in the next bank review extensive committees and the board. So we've got that in. So it's adding in and making sure there's more balance.
Great. That's important because the terms of reference were approved by the committee. It's for the board to approve that.
It's subject to.
I think we've made those changes. We agreed. Yeah.
Are there any other questions?
No, I just want to reiterate something which Dave said earlier, so we don't lose it. So just to circulate the green plan, round to the board before the next one. I think that's what we're saying.
Send it round.
Yeah, because it is quite a comprehensive document, that's it. It's got Dave's picture, you've got your picture in there, mine. Unfortunately, it has. It's got a very awkward double act, you know.
Well, thank you.
Very
Thank
nice.
you. That will be.
It's a long time ago.
So what you said, Jerry, I'm going to lose on. So, I'm going to move on to the integrated performance report.
Okay, so we're already talked about some of this anyway. This already goes to the individual committees and they've all set up in various stages around it. Again, just emphasising what's already been said, the view was about commentary becomes is helpful, but we do need to see this. What's the trajectory for improvement? How are we doing this? What's the impact we will see? We agree that what's in there now in terms of the way that we can do that and thought that, and that's a bit that works and helps us with that. There's nothing else particularly going to flag up for the board out of this, because we've already talked about the issues out there, etc. So I'm happy to take any questions, but I wasn't saying more than that.
Well, I mean, obviously this report, as Dave said, goes to all committees, and committees get cited in this issue.
So on that basis, then, I just wonder whether or not, so on page 1, we talk about the performance in February and we make reference to FPP discussing certain things, but we don't make reference to any of the other committees discussing things, whereas actually what you've just described is that they're called to do. So I think for consistency, we ought to be clear that these things, what has been discussed in the meeting, as part of it.
I think it's also good to note, and we mentioned it earlier, just around the opportunities that provider clarity brings as well. So I think about, all the trajectories, the targets there, specifically around IAPS, out of area, absolutely working as a system to help and support and to enable, to hit that target, and, absolutely being really aware that, placing someone out of area, obviously there's a financial impact. There's a real quality impact, the impact it has on someone not being able to see their loved ones, so it does affect their recovery and increases their length of stay, as well as obviously from a sustainability point of view as well. So, just to reinforce, we are working with partners around that, and it's not just all the NHS, we've got voluntary sector organisations that work with us around IAPT that have a great offer as well. So yeah, I just wanted to make sure that we've noted that as well.
No, so just looking here, obviously, bank and agency fill rate. When we're talking about collaborative, something that I mentioned with the other chair colleagues, just to start thinking about creatively down south, they've got shifting from competition to collaboration, and thinking about having a collaborative bank. It's been working across the house, there you go. Okay, I'll say no more about that. Okay.
Yeah, I think, you know, again, to note in the report, there are some, you know, we could be improving, and I think board colleagues will be very aware of me sort of, I've been sort of, you know, focusing on my rate. So absolutely sort of trying to have very, very supportive conversations, trying to enable people actually to really sort of focus on what we need to improve, and trying to support, particularly around the banking agency, we're planning to have some sort of deep dives, again, supporting around the individual divisions, around where the hotspots are, how can we help, how can we support, but within the long-term view of actually, we've got to reduce this, you know, and how can we do that together collaboratively. So myself, Richard, from a finance perspective, HR, are going to be actually having those conversations, and the nursing directorate as well. We'll give some outcomes of that in a couple of months' time, so we'll get through all the divisions and sort of see if it's made, what differences has it made.
Excellent. So are there any other questions, I should say, could they? So
Just wanted to add to the point that Vanessa made, because we've had conversations in finance committee and also with people, even looking at where the demand is coming from, we can see to do that we have more demand for shifts, and we can't satisfy that demand. So we need to really look at the root cause where the demand coming from, and that's the way that Vanessa is describing, which will really help us to really understand some of this, because it's not just about turning off the tap in the back office to say, well, we're not going to be able to authorize the shifts, because there is a reason why they need those staff to work on the shifts. So I think that's really helpful.
And just to add to that, I mean, in terms of the reasons, there's both a number of thanks because of vacancies, but also the levels of acuity.
Yeah.
So clinical requirement is quite a significant category in terms of the requirements. So in itself, our strategic approach to how our demand is changing, you know, the clinical potential, the clinical model, and the clinical response that goes with that is quite important, isn't it? It's going to be one, it's becoming, it needs to become a very significant conversation, one would think, across the system. Because you know, if the demand demographics are changing, the services have to be able to respond to it. Or, you know, decisions, unfortunate decisions.
Historic area where it's been the biggest task has always been secure, and that's not changed. So we've got the additional communities emerging, but the secure feels like it's intractable. It's a long term.
thank you. Thank you for those questions. We're going to move on to the finance report.
Okay, so there's a few bits in here over the book what I've normally go through. So in terms of the year that we're finishing up now, and I can say fairly confidently we will have break into the year. We can plan that up for several months. I think Val's right. It's difficult to be hard and fast. You will break even, you will do this. That's always difficult. But we've been confident for one period of time we wouldn't be. The difficulty is how we do it, as you said before. There's a significant uptick in terms of capital spend in February. That reflects two things, both additional activity, we did expect anyway, but also catch up around the accrual for the work that's been done. There are things that you need to do around that. I think it's fairly certain we will actually overshoot capital rather than undershoot. And that's not really an issue. It's worse if you don't spend because you lose. It's likely to be that there will be some unspent across the system. So anything that we overspend does offset that. Around the capital. We're reported at the next stage, so there is discussion which you might want to add into this about what happens in terms of the system discussion on the two big texts. So go through the next stage, got us to a 3 million deficit on the basis of largely There's some spending that we forecast, mainly around the mental health investment standard and plan, that we be expended, but it's been duplicated elsewhere. So it's been allowed for in one of the other organisations, straight duplication. A couple of other things, but that moved us down to a 3 million deficit. That's not to say we will achieve it, because it does depend on delivering some of the savings targets that we've got. So this isn't confidently saying we can achieve that, it's saying that what's been submitted. Now, since that, there's been further discussion across the system, so that all of the organisations and the system as a whole is now submitting a break-even position. So for us, that's saying we'll break even rather than 3 million deficit. It does increase the pressure for us, but there is elements where there is likely to be additional monies to support excessive non-paying expenditure or inflation like energy, and for us certainly on UHB, PFI, private finance inflation. So some of that will be offset by those coming in anyway. And there is support from the state around this. So at this stage, what's being submitted, and it's not gone in yet, but what's being submitted is a break even for the system and a break even for the organisation. So that,
Yes, that's a break even for the system. I think the talk is that if that actually has been put forward and there's a guarantee that the next is between 15 to 20 million.
that's the discussion.
Yeah.
Yeah, so I think the negotiations around the solution are ongoing. I think that's probably what we want to report publicly.
Yeah.
To you, that we're still having those discussions, because we've got real risks and challenges around putting a plan forward for break even, that if we can't offset them in some way, we wouldn't be in a position to submit it. So those conversations are still continuing.
So where we are at this stage, formally, we've submitted the 3 million deficit in the way that's described there, but it is likely that we'll move forward to that position, but as Richard says, that's still to be determined. So that's the overall position. It doesn't particularly change the discussion we've already had about what we need to in terms of transfer information, etc. So that's the key issue for us. There was also a piece around going concern reviews. So as part of what we do around annual accounts, we have to say whether it's appropriate to prepare the accounts and the figures on a going concern basis, i.e. the organisation, or its services we carry on. In common with all NHS organisations, we have used that adoption in the past on the basis that the services will be carrying on anyway, whether the trust carries on or not. So it's appropriate that you use a going concern basis. FBP endorsed that, and it will be coming back as part of the audit committee piece to make sure that the auditors, external auditors also confirm that we're able to say that. So we're looking for an endorsement or approval of the recommendation to use a going concern basis. And then the last item, there's 2 final items. So there's a capital programme for next year. So we've already talked about an element has already been in principle signed up around statutory standards of backlog maintenance, some which is on wards and clinical areas anyway. ICT, cancer inclusion suite that's externally funded and completing the inpatient door sets, and that's described in the check summary. We've then finalised the usage of the balance of 2.4 million. That's been reviewed by the Director of Operation and Nursing in line with the process that we've agreed, the prioritisation process, and that's been included. The 2 committees, finance, performance, productivity, and quality, etc., have reviewed those and recommended their approval. So we need to formally approve them today so we can actually do that going forward. What we're approving is the allocation envelope. It's drawn down there by the business cases being released, prepared, etc., and that comes through the capital review. And then lastly, around contract review for SSL owned sites. So we've got a number of long-term leases in effect around sites that SSL owned. It's listed there around Tamarind, etc. That they've either expired or they're due to expire. So I've put the data around those. We've also got a number of ongoing ones that we're proposing, and this is around Rayside, etc. That we're proposing that when they end, technically end on December, that we roll them forward to 2043. It's not that we can't change that as we go through, so we can always change them at any point in time, but we do need to have these formally extended or not. there isn't an alternative described in the paper. There are alternatives, but none of them are all really viable, things that we can do in any different way. So you couldn't use different size, it's really possible. You could transfer it back if there is major financial transaction issue, and you'd have to justify that elsewhere as well. So the recommendation is that we do the approval of the contracts that have already come through, but also pre-approve the future ones going into it. Happy to answer any questions, but there are quite a few things that we need to do. So I don't know if you want to take a question on the individual areas and come back to some of them.
Can do that, actually, David. Are there any questions?
I think for me, so Dave, thanks for a very clear, comprehensive report. I think for me, in many ways, the old year's gone, right? Thanks for breaking even, I recognise that. If you think about the year started and the cost of living increase, storage prices, that's quite an achievement to break even, to be honest. Because that leads to the uncertainty that experienced during the year, when the centre was going to fund it, when the vote going to fund it, as well as the industrial disputes in relation to staff pay. So I think as a board, we have to acknowledge that, and it's subject to all this, of course, which is much break even. I think for me, the financial outlook for next year is really worrying, because you remember, if you look at the tables in the report, we go from a £38 million to 21 down to 8, and then now being asked to submit a break-even position, which I think was
not next.
It's not quite.
It's 3 million debt.
3 million.
But there is the potential.
Yeah, and so within that, there's going to be some degree of uncertainty within that. I think we need to, as a board, keep an eye on where those areas of uncertainty is not going to be, because what may happen is we play the game by the system, and then later on they go, well, actually, you're not going to get there, why are you getting there? So Bal's point about, the cost improvement programs and making that in place is fundamental. We also need to keep our eye on the fact that these things can go wrong. So for me, the question really is about, I was concerned about, is it MHIS funding?
Mental health investment.
Yeah, investment funding, which you'd initially put in and then been asked to take out again. And my question there is, there's a worry that the system expects you to do those improvements, but within containing the cost.
Just clarify that one, Winston. So effectively, the first one we're talking through, the 8 million deficit.
Yeah.
We've assumed as a trust, we had the expenditure associated with that. Some of that expenditure sits elsewhere. So for instance, FTV, or voluntary sector, or ICB.
Right.
So for us to include and them two, it's a double down. So they're not asking us not to spend it. What we're saying, it's already allowed for. So it's when you look across the system, it's taking out the duplication.
Okay. Okay.
So it's a valid point. We've got to watch this.
Yes.
Us having an organisation issue through trying to play the system game.
Yeah. So that was just more comments, observations about the flashback. But again, I definitely endorse the proposal on the SSL.
Yes.
Proposal. That's important that we allow you to get on with that. Really.
Yes. Any other questions?
So could we just record the decisions around this or the agreements for it? So I'm looking for them. Agreement with supporting going concern use. The capital programme that we've got has been recommended by the committees. And contract renewal, which is also. Yeah. Oh, and
And the commercial plan.
yes.
Remembering there's the word plan.
Yeah.
Yes. Thank you.
It's a position I think on the one.
Okay, thanks, Dave, for that. You report quite a challenging year ahead. Yeah, definitely. Okay, so if we can move on with our agenda and move to the gender pay gap report.
Yeah, can I just get to the first?
Just like we'll have 2 minutes.
I didn't think you were thinking of that.
Yeah. So we're trying to save for money.
Hi, Jazz.
See this way? No, see this way so that the camera will get you. There's no camera where, there's no camera here. There's no camera here.
Hi, Jazz. Hi, Jazz. A few people are just taking a quick conference break.
No problem at all.
It's hard going when you've been here since 9 o'clock.
I bet.
Definitely do.
But one other thing, doing, through the constraint side. So, it gives you highlights, and then I think there probably will be a number of questions. So when you don't need to go through it, page by page.
No problem.
And because you do go to.
Yes.
The, and the rest of it.
Yes. It's all been here, isn't it?
Yeah.
Yeah. We started yet.
You do the drink.
Jazz, you're on a hot seat.
Yes, David, please, that's
Feel relaxed.
David's talking a lot.
It's a very nice family.
So there's a couple of others actually, but you can start take insurance.
Hi everyone, I'm Joss Cole, head of equality, diversity and inclusion for the trust, presenting 2 papers today: the gender pay gap as required legislatively, and the regional and national comparison of the workforce equality standard. I'll start with the gender pay gap, get my teeth in. I'll take the paper as read, and with the key headline in terms of the gender pay gap figure slightly being reduced since last year, and considerably lower than the 14% national average. I'm happy to take any questions or points of consideration or conversation.
Yeah, so I think you've made a really good paper of helping us understand, helping anyone reading it understand what one really means, because it is really, it's complex and it's quite difficult. I'm particularly interested in recommendations, and about whether or not we're intending to socialise those, and maybe add to them as we socialise them as well, whether or not there are plans to, what timeline plan is for us to be able to do the work around encourage, taking it to divisions. And I know you use the word encourage, which is great. Probably wanting to be really clear on this, that we think divisions have the kind of devolved accountability for thinking about this alongside thinking we're doing more centrally.
So once this paper has been approved here, so there is a kind of legal publication requirement which has already been completed. The plan was to roll out through the FPP function, and to do it in partnership with the Data with Dignity approach. So colleagues across the board can see the link in terms of improved experience for our colleagues in relation to improving the experience for our service users. And also, historically, I think there has been a feeling around this is something that's corporate, but actually that local ownership is fundamental in making the changes, because all the recruitment and all the growth happens locally. So that's why that local encouragement word was utilised, with a nudge towards ownership and accountability. Because those conversations have only just started, that is the rationale behind the encourage language. But there is a robust rollout plan, and I'm hoping to take it to people committee in relation to the workforce race equality standard, the disability equality standard, and the gender pay gap as a data set.
Do you think we should be being a bit clearer about where we want to see ourselves in a year's time. We've obviously seen some improvement, we've seen some, you know, kind of going backwards. So is there something about needing us to think about what journey we might go on to what are the things that we might need to do to help us get somewhere else, and maybe doing some appreciative inquiry with others that have managed to do that when we do.
So some of that appreciative inquiry approach has already started in relation to the conversations with the Women's Network in particular. And also from our pay gap, we also highlight differentials across ethnicity, disability and sexual orientation. So the link, there's a massive success story here in terms of sexual orientation pay gap actually being exacerbated by the deficit. So that has started, but because of the nature of the paper in relation to it being quite a legal requirement, and me understanding further as to what do we need as an organisation that will help us, I think in future papers you will see that transition. But this one is quite formulated in that type of approach.
I think it's helpful because, you know, we had some discussions to say it was a very sort of factual report rather than sort of some of the questions like machines are not going to repeat the machine as just said. So it's helpful to hear that this is actually legal support that you are presenting for us to endorse, and then in the future we can start to look at what are we doing about it. Yeah, the so what question. Yeah.
And that's why in terms of the assurance element, there's a limited assurance around this. So this is almost reassurance.
Yeah.
This is the point in fact statement. So the assurance will come through the conversations through people committee, and then escalated by that route, and also through the conversations in, I know you're having an update on the health inequalities conversation. This has a significant feature in that dialogue. So actually, how do we link all of the different pieces together to make sure that we've got the best positive impact for our communities?
Thanks, Justin. Really helpful reporting to some great breakdown. Agree with Roisin, I can be very complex and just see number. I think it's something about how we bring more to life around stories. And I've had a number of people asking me more recently to say, how do we get here? So in capturing some stories, maybe working with networks in terms of, and this is what it looks like. It's really helpful for people to understand that this is how we get here. This is some of the experiences. So this is something that I think we can think about how we do that.
Definitely. So one of the conversations that we've already started is around the ethnicity pay gap with John Travers as to the link with the Workforce Race Equality Standard, but also the narrative that's out there in the wider organisation, how we support the factual element around that. So that will stem across all of the protected characteristics that are highlighted in relation to making sure that it comes alive essentially. But also there is good practice that we've learned from the Workforce Race Equality Standard in terms of our commitment to the Blackley report, whereby we stated that we were going to include colleague voice within the Workforce Race Equality Standard as a fundamental principle. And that can be easily transferred also. So going forward, we will have a more engaging document.
Could I just ask as well, my understanding, it might be what people understand, but my understanding around this isn't saying we pay people that do the same job differently. What it's saying is, effectively, some people aren't able to access higher paid jobs. So it's actually that we've got to focus on, make sure we understand, because it can be interpreted differently. I think it's important. So it's what we've already talked about, the accessibility of jobs, rather than what we pay people. It's just important to get that message.
It's a symptom of
Yeah.
So is that the clarification then, that it's a reflection of where people are playing in the organisation?
Yes.
The levels they're at. So as an organisation therefore, so in terms of, looks like there's still a gap, we're slightly getting better at that in terms of gender.
Sorry, I didn't.
In terms of gender.
Yep.
in terms of gender. There is a gap, and we're slightly closing that gap.
Yes.
But when we look at, and in terms of sexual orientation,
Yeah.
we've not only closed the gap, we've reversed it.
Yes.
So that's a good thing. But in relation to disability and ethnicity, disability, we've got slightly closing the gap a bit more. Ethnicity, it's got bigger.
It's got worse.
It's got worse.
Yeah.
And you'll know from the next report
Yes.
that there was, I think it's the likelihood of candidates shortlisted for job interviews, if they have an ethnic background, they're unlikely to get the jobs. So as an organisation, we need to think about how we do something about that. Because if someone goes to apply for a high job of an ethnic background and they're unlikely to get the job, all we're going to do is increase that gap over time. Not the organisation. Yeah. So we've got to just go down as to what we do overall as a corporate body, but also if there are particular instances in particular directorates, what can be done about that? And that might be coaching, that might be awareness training, that might be those people applying for the jobs, putting themselves into the best position to get that particular job. I don't know what the answer is, right? But I don't know what the answer. Yeah, there's no easy answer. Yeah. Absolutely. Yes. So I think that's what this report seems to send to me, that, okay, yeah, it's to do with where people are, but it doesn't really boil down to what we need to do about it. And that's not all in your hands, by the way. That's what we have to do as a whole organisation.
Yeah.
That's next.
That's next. Yeah.
That is also ties into what Patrick mentioned about the story. So actually, we've made a really strong, assertive commitment to becoming an anti-racist, anti-discriminatory organisation. This data isn't filtering down to operational colleagues because there is a certain narrative that's being carried as to if you're from a particular group, you're only likely to get the job if you're from a particular group.
Correct.
So actually sharing this data and socialising it's fundamental, because this factually tells you that's not true. And so do the recruitment statistics, and so does the experiential data.
And we've still got a lot of people who aren't feeling like able to share their data with us. So actually, we're not getting a full enough picture. There's still some gaps in terms of people's ability to share.
Yeah, that comes out strongly in the next report.
Yeah, a little bit of Patrick in.
Yeah, I think just kind of take Dave's reasons. The element around some of the stuff is really around accountability, because what you tend to get is, well, this doesn't really resonate with my team or my service. But I think that's where the issue is. If there's no accountability of this is my contribution to this issue, they will always be in that situation. So I think being able to articulate sort of what are some of those barriers, making very clear through stories, because we have people in the organisation share some very powerful stories about some of the barriers that they experience. I think that will start to make it feel real than just the numbers.
Just one thing that is found in SSR, we doing a similar thing. What was apparent there was they were only capturing the declaration of time people were applying, and that isn't necessarily what people will be prepared to do now. So it's just understanding, do we go through and check people on an ongoing basis, or ask them to verify what it is, or is it just what people put in the time of application?
We've also got, just in response to that, Chair, we've also got, you might have noticed them in the open areas, we've got flyers with updating your ESR information.
That's important.
And that's being socialised through Teams as well. So those are all out there in terms of really clear instruction on the why is that data important, and actually some key statistics on there as well. So we're encouraging everybody to look at that. Encourage colleagues around the table to update it, to be honest, in terms of there are a couple of gaps in terms of, just leading by example. And when colleagues ask us, and we've got that experience to go through as well as to, it took 2 seconds, I did it on my phone, it was really easy. And that type of narrative in terms of that organisational and process advocacy.
Brilliant, thank you. Well, Jazz, do you want to just naturally move on then to?
Sorry, before you go on, I just thought something else was going to arise. Do we have to call this agenda? Legally, there's a requirement, and there is a requirement for you as a board to be cited and discuss the gender pay gap as a legal requirement.
That's 2 different things then, isn't it? So calling it something, and being cited on the gender pay gap are separate things. So I
I'm
suppose.
happy to go with whatever you feel comfortable with as a.
We have to publish this as the gender pay
As the
gap.
gender pay gap.
It's legal and it reflects other gaps.
We have to publish it.
If people are interested, they'll like, they'll see. No, this is all the problem that you've got, and then that's the problem is. We might look at it, go gender pay gaps, and then they're not interested in that, whereas they might be interested in disability pay gap. So anybody that knows me will know that I love a good slide deck, and on the slide deck, just for ease of access, so what we've been working with local communities is around, they want to understand this information too. So actually just a really basic slide deck as to the gender pay gap, the ethnicity pay gap, or key headlines. And also looking to do some infographic information so that it can be socialised in an accessible way. And often we can't really choose straight sticks. So within that communication, it will be really explicit.
Which is what it is, but yeah, thanks, Jazz, yeah. You want to take last point?
Yeah, just a quick one for the purpose of the minutes. We are approving the report because that is an act of thank you.
Yeah.
Thank you.
Yeah, and the recommendations.
Thank you.
That's something to move forward. Okay. Jazz?
Thank you. So I always try and pull out some positives. But it was quite difficult in the Workforce Rating Quality Standard. Because if you look at the summary in terms of the regional visual, all you can see is red and ambers. There's one green, which is really great, and I really want to kind of congratulate us on as an organisation on getting that broad visibility and leadership, because operationally, I'm hearing that gives us the visibility around, if you can do it, I can do it, and I'm actually hearing that loud and proud. So that is one massive point to celebrate. But we've still got a significant amount of work to be done, especially around the experience of our colleagues. And you can see from a regional and a national comparative basis, we're not faring very well in a majority of the areas. I'm happy to take points of discussion, but I'd just like to point you to the fact that we have got a Workforce Race Equality Standard Plan, which was ranked by the Workforce Race Equality team, graded from points 0 to 3, and we scored 2.3. So the bit that we just need, it says dialing up on, is the principle of local accountability. So the senior accountability is there. So thoughts are going into co-producing a response to that through ADs and CDs and local divisional areas. So that's just a bit of, and we also do have the model employer commitment that we made in terms of becoming a representative organisation at 40% in terms of Black, Asian and White ethnic communities. But I have to take any points of concern, question or celebration if you find.
I think your summary is spot on in terms of, that until there's some more green here, we need to be really clear that the people committee is, this is one of the domains that we're expecting to, and we know that we're looking at on a regular basis, but that devolved accountability through using our divisions to think about what is their next time, what does this mean for them, what does it mean for the points that Winston was making in terms of are there people that actually they could support by having a cohort of coaching? Are there individuals that need specific training around when recruiting? So I think there's this particular bit that we still need to crack. And your point about this, we've got this contrasting story where some of the comments that have come through in the staff survey are suggesting that actually if you're white, now and are much less likely to be, promoted. This evidence, there's no evidence that that's still the exact opposite. And so there's a message that we're getting a message out, and it's clearly landing. So how are we going to make it real? I think is the, and I think we can only do that through supporting local teams to think about how they're going to do that and being there to give them the kind of interventions that will help them do that.
And just to give you a little bit of a snippet in terms of one of the actions already in situ is the relaunch, let's call it, of the inclusive recruitment approach, where that puts sole accountability of diverse panels in terms of gender and ethnicity on the panel chair. So that's the excluding the principle of an equity panel member and the EBE. So actually the main panel needs to be visibly diverse, because that principle of if I can see myself in you, I will perform better. And that's really explicit. So what we're trying to do is equip people with the narrative, because that's what they're finding difficult in terms of when they are looking for representation.
I totally agree. With this one, really,
It is.
to receive this, because the dam doesn't appear to be shifting over a number of years from way before both our times, I guess, is the issue. And you would hope that that is the case. It has changed in terms of all the years, actually filtering down. It isn't, and I guess we'll be more in terms of the staff survey as well, in terms of how people feel of their experiences. So we have to do all that we possibly can. So if there is anything else, just that you feel that we as a board can support or assist you getting sort of key messages out, then you have our full support where that's concerned. We're 100% behind it. It means jumping on, this is not right, we'll do whatever we need to do to see how we can shift and start to see green shoots.
I do have a really simple ask that I wanted to put in the paper, but I didn't feel like it was paper type of ask. And that one ask is for you all to individually and collectively think about how this integrates into your business, but also your being as people. And that's the bit, it's not necessarily the listening parts, it's the conversations you have. It's not necessarily the big shiny thing, it's when you're stood outside and you're having a conversation with someone and they're reflecting and how we challenge back. So that's my ask, and that's why it wasn't a paper type of ask. But that would make the world of difference, I think. So thank you for allowing that opportunity.
Yeah, thank you.
And we want to allow you to put the same challenge out to senior leadership team and discuss in a couple of weeks' time.
Yeah.
Judge, thank you.
Thank you
very much for both reports.
Thank you.
Start survey.
Yes, sure. So just presenting the paper on this survey. I'll take this way, but I'll just bring up some key highlights. I think first of all, I just wanted to thank our staff who took the time to respond to this staff survey. I think it's helpful to highlight that we have maintained our position in terms of our response rate from last year. If you look at the previous year in 2020, it was on 47%. So it was really good to see that our staff was still committed to really share the feedback in terms of how we can improve the experience of being part of this organisation. And also, we have improved our position in terms of the number of teams who receive feedback, linking into what we've just been discussing, which is how do we ensure that there's local accountability and teams reflecting on one slide to work within that team, and to have moved from 64 teams in 2020 to now 92 teams. And that shows that our local leadership are starting to really focus on how can they start to think through about the experience of working with individual teams, and we want to continue to maintain that trend to increase the number of teams that get feedback globally. And just to highlight as well that this is the first year that we've had feedback from bank staff. Response rate for bank was 30.1%, which is 6% above average nationally. So that's a good start, and we want to maintain that as well. The results are definitely showing us that some of our long-standing concerns still remain, as sort of conversation we just had. When you look at the people comments, we are below average on 8 of the 9 things. In the people comments, we remain static in the area of equality, inclusion, and diversity, as we've just discussed. So there's an example on a specific question where we ask whether colleagues have personally experienced discrimination from a manager, a colleague, or any other member of staff in the last 12 months. Our score is 13.7% of our staff say yes, they have experienced discrimination in the past 12 months. Last year, our score was 12.6%, so slightly worse than last year. But the worst comparative trust is 13.8%. So it puts that into perspective in terms of where we are as an organisation when it comes to equality, diversity, and inclusion. Also, in terms of recommending the trust as a place to work or to care or